Good morning. Principal sir, good morning.
Very good morning, sir.
How are you, sir?
Fine, sir. Doing well. How are you, sir?
Yeah,
Hello.
doing good. I think I have seen you when I came there like 4 years back.
4 years back. Even during examination, are the any CME or guest lecture, sir?
CME. Your VC was a pathologist, no? My friend, I suddenly blocked his name. Dr. Rahivir was there. So when he came, you also came.
He was vice chancellor then.
Yes.
Now
Rahivir sir, where is he, sir, now?
now he is in Enopaya, sir.
Okay.
Enopaya is a pro vice chancellor.
Oh, very good. That's the beauty, sir. Once you become VC in one place, you will be VC throughout your life.
Remember.
I wish you become a VC very quickly, sir. But you should like it. It's administrative headache.
Thank you, sir. But the chancellor, Dr. Pradeep Kumar, is there. Is a forensic professor. He is doing well. And
Okay.
he is also from KMC Manipal.
Okay.
Before Raghuveer sir left KMC, he was there as a dean.
Oh, okay. Okay. Swaroop, are you there?
Fine, sir. Doing it. And sir, what about the COVID situation?
Yes, sir.
Yes, sir.
COVID situation in your place?
It's almost zero, sir. We have 2 patients. And we all started vaccination. And I have to take my second dose after finishing this meeting today.
Same scenario with me.
Sure.
I'm supposed to go there at 10 o'clock and take my second dose. But for us, cases are in the single digit.
Yeah.
5, 7, 9. But the point which is bothering all of us is the increasing in trend in Bangalore.
So there should be some reason, sir. Probably they are not wearing mask or not maintaining the social distance. When you do these two, definitely it will come into.
Sir, along with the 2 points which you have mentioned, the other thing is the floating population. Because Bangalore is main business center in South. The people coming from Bombay or Kerala and other parts of the country is too much in Bangalore. As far as the airport is concerned, that is the third busiest airport in the country.
Okay.
And next to Delhi and Bombay, then comes is the Bangalore.
Yeah. Maybe we won't get the second wave or third wave, sir, because first wave itself is not over.
But maybe in the month of March end or April, because that is the time the climatic conditions will get changed. We should be doubly careful.
Yes, sir. No, we have to live with the mask for another 1 year. That is for sure.
Another 1 year it's.
But I buy all designed mask now. Make it more colorful.
But for you, it is fine. Because for me, you just carrying always double mask.
Super, sir.
Being a surgeon, whenever I go to OT, on top of this, one more mask will come.
Yeah.
Along with the face shield.
Yeah. Very difficult, sir, for surgeons. Luckily, they switched on the AC. Previously, they switched off the AC also. So very difficult because those rooms are built for air conditioning. Yeah, no air will come in or out.
Now the principal office, the AC was switched off almost 8 months back. All the doors, whether it is outside door or the windows, All the cross ventilation is made sure that windows are open and things are going on.
Yeah.
But the only thing in the library, we could not able to open the library beyond 6 o'clock in the evening.
Okay, okay.
Because usually our library will be open till 11:30.
Students are coming, sir. In our university, students, everybody got the books in iPad and iPhone. Nobody is coming to library.
But somehow our students like
Very
to come
good.
to library.
Very good, sir.
But the 6 o'clock we are closing now.
Okay.
And between 6 to 9, departmental libraries, they can open. Because departmental library are not air conditioned.
Okay.
So that cross ventilation will be there.
We have reading room in all the hostels. We kept it open 24 hours. So they go and read there.
It is the same scenario with us also.
Yeah. And they can bring the books, and the library, they cannot bring their books, no. Whereas the reading hall, they can bring their own books, computer, everything.
Sir, even in the library, we have just created one separate wing where they can carry their own books and read.
Yeah, self-reading area.
Self-reading, that will accommodate somewhere around 200 students.
Yeah. Now we have the same facility, but nobody comes to library. I think they are more comfortable in the hostel.
Hostel and their own laptop or iPad.
Just before Corona, we opened a free coffee service in the library. I think it's not a very good idea. After that, nobody is using it.
It's true, sir, but the nowadays library is becoming the requirement of NMCA and the other statutory bodies.
It will drastically disappear, sir, because new NMC is agreeing. Old MCA is not agreeing. You have to buy journals for 5 crores and all. Everything is available online. Who will come and take the journal?
See, nowadays the online journals are so freely available, and you share with the mobile phone, they'll
stop
reading.
Because of Corona, everybody are giving for free. Previously, we have to pay some money. Now everything is free.
Free journals.
Yeah. So, see the technology. I am asking for this type of meeting for the past 5 years. Nobody listened to me, but now they are forced to do that. So I am very happy. So many meetings are happening over the Zoom and Google Meet. We are more productive now.
Now that is become part of our routine life.
Yeah.
And all these teaching programs are going on through Zoom only. No.
Yes, sir.
Except allowing the students for the clinical postings. And now the first year exams are going on. And final year exams are going on. Once they finish their exams again, I don't know whether we are supposed to continue with the Zoom or switch over to the offline classes.
We are planning to do both, so that people can come here as well as use the offline if they are not able to come.
And how we are planning for the attendance, sir, students?
Attendance we take at the beginning of the lecture class. The Google Sheet will come now in Google Meet.
Okay.
They have excellent facilities, and Zoom also they have their attendance sheet.
Okay.
And we insist the students to switch on the video. Otherwise, they just to switch on the computer and leave.
True.
So we are insisting you have to switch on the video, sit in front of the video so that we can see them.
They are very, very good at it.
But the standard has come down, sir. Corona psychologically affected students. The even well-read student is not able to answer that well in the exams. For them, in that age, it is like a pandemic. Going across a pandemic is a big challenge.
Sir, the one side that is correct, but the other side is when the students are getting used to these online classes and using these gadgets, they're searching for the answers for any questions during your class or interaction. It will not help them in any way.
Yes, sir.
If I'm right, your time or my time will be asking the students to giving them the provoking thought. When they go in search of that answer, see this side 1, 4, 5 chapters, that side 1, 4, 5 chapters, he will try to search for the answer and get some more points.
Yeah.
Now that system is not there.
Yeah. Super, sir. We will ask Swaroop whether it is ready. Swaroop, you take care, Swaroop. Thank you, sir, for the nice interaction.
Thank you, sir. Swaroop.
Suresh, sir.
Swaroop. Suresh.
Hello, Dr. Rajendran. Good morning.
Good morning, madam. Thank you for joining.
Of course. Hello, Vani madam. Hello, Vani madam. You are unmuted. You are muted, Vani madam.
Can you hear me?
Yeah, yes. Good morning, madam. Good morning, Vani madam. Sandhya here.
Sandhya,
Yeah, hi.
you can put on your video so that I can see you.
Okay, sure. I will. Yeah.
Okay.
So good
That's
morning,
good.
madam. Good morning.
Very good morning to all of
Yeah.
you. So I suppose in a couple of minutes you're going to start.
Yes, ma'am. Yes.
Yeah.
1 more minute.
Yeah.
Madam, Madam, good morning. I am Dr. Sri Ramlo, principal of the college.
Very good morning to you.
Thank you, madam.
Very good morning to you. It's wonderful to be in this group. I wish it was a physical meeting so that we all could have come to your college. But given this situation, I think it's better to have virtual for some time.
And the situation is other, it will be having an offline meeting, madam. That time will come.
Sure. I'll be more than willing to come.
Sandhya, madam, good morning.
Good morning, sir. Good morning. Very nice. Excellent program, sir.
Sri Ramlu, sir, is a very good friend of Balaji Singh, sir.
Yeah, okay. Good, sir. Very nice to meet you online.
Nice talking to you, madam.
Yes.
Good morning, sir. So we'll start, sir.
Sure.
Good morning. I, Dr. Soumya, welcome you all on the behalf of Department of Pathology to the online pathology CME on molecular pathology conducted by Sri Devaraj Medical College. Molecular pathology is a yet rapidly developing field of pathology with most current classification of tumors incorporating them and thus proving their role in not only diagnosis but also in the treatment of most tumors. This CME will aid faculty and budding pathologists in understanding the techniques and applications of molecular pathology into routine histopathology reporting. Now I invite Dr. Kalyani ma'am to give a welcoming address. Thank you.
Very good morning, ladies and gentlemen. Today we are organizing a CME. That is the theme is the molecular pathology. And at the outset, I would like to welcome our patrons, that is in absentia, Shri R.L. Jalapaji, founder chairman of Shri Devaraj Education Trust, and Shri G.H. Nagaraja, secretary of Shri Devaraj Education Trust, Shri Rajendra J, administration and finance director, Shri Devaraj Education and Trust. I would like to welcome our Honorable Chancellor, Shri Rajesh N. Jagadale, Shri Devaraj Academy and Research, Dr. Pradeep Kumarji, Honorable Vice Chancellor of the Academy, and also I welcome Dr. CME Prasad, Register of the Academy. I welcome Dr. Sriramlu PN, Principal, SDMC and Dean of the Academy, Faculty of Medicine. And I also welcome Dr. S.M. Hazim Moyuddin, Medical Superintendent RLJH and RC, which is affiliated to Devaraj Medical College, and Dr. Shashidhar K. Vice Devaraj Medical College. I welcome all the speakers, reputed speakers from the premier institutes, Dr. S. Rajendrian, Dr. Vani Santosh, Dr. S. Rajendrian from Shri Ramchandra Institute of Higher Education and Research, Chennai, and Dr. Vani Santosh, Professor, Pathology, NIMHANS, Bangalore, Dr. Swarna Shivkumar, Senior Consultant, Histopathology and Cytopathology in charge, Apollo Hospital, Bangalore, Dr. Biba Chowdhury, Faculty Scientist, Institute of Bioinformatics and Applied Biotechnology, Bangalore, and Dr. Manjunath GN from Devaraj Medical College. I welcome my staffs of my department. I welcome all the postgraduates of my department, and I welcome all the delegates and the participants who are attending today's webinar. Department of Pathology, that is at Sri Devaraja's Medical College, is actively involved in research activities, and it is committed to postgraduate and faculty teaching by conducting annual CMEs for more than a decade with eminent speakers and on relevant topics to enhance the knowledge of postgraduates and faculty. And we took this molecular pathology, which is an upcoming topic, to sensitize both the budding pathologists and the consultants, because it is taking a major role, especially in case of cancers, for classification, diagnosis, and also predict the prognosis. So hope the conference goes on smoothly and will be successful, and the delegates will be taking, the knowledge of this and applying in their practice. Thank you.
Thank you, ma'am. Now I invite thank you, ma'am. To enlighten regarding the molecular pathology in breast tumors, we have with us eminent speaker from Sri Ramachandra Institute of Higher Education and Research, Chennai, Dr. S. Rajendran, Professor of Pathology. Now I invite Dr. Kalani and HOD of Department of Pathology to introduce the speakers.
Good morning, sir.
Good morning.
Yeah, I have the privilege of introducing you for you're the first speaker of, and sir is, as I think sir doesn't need any introduction, but as formality, I'll be introducing sir. Sir, that is Dr. S. Rajendran, Professor of Pathology at Sri Ramachandra Institute of Higher Education and Research, Chennai. Sir has done MBBS from University of Madras and also MD Pathology from University of Madras, and later he has done the diploma in RC-Path, that is from Royal College of Pathologists. At present, sir is working at Sri Ramachandra Institute of Higher Education and Research. Sir, in addition, also has done the fellowship in College of American Pathologists, and also fellow is United States and Canadian Academy of Pathologists. Sir is the member of various academic organization. Sir has also, he is the invited lectures at the various platforms, both in the national and the international level. And sir has good number of publications in indexed publication, both in international and national journals. And sir has also presented good number of papers in various conferences. And over to sir, that is, sir will be speaking about the molecular pathology in breast tumors. Sir, please take up.
Thank you, madam. Thank you very much for everybody in joining. And this is a very apt title. Everybody should be knowing about the molecular pathology. And I thank the organizing team for involving me in this educational extravaganza. Just to do some checks, I will switch off my video so you don't have to see. And I will start sharing. Swaroop, is my voice all right?
Yes, sir. Your voice is audible. I can see the cursor also, sir. The red cursor.
And the slides are ready.
Yes.
Super. The most spoken word now is, can you hear me? And unmute yourself. So I kindly request all the delegates to mute yourself. And if you have any questions, please put it in the chat box. And Swaroop, Suresh, and Kalani madam and team will be able to get the answers from me at the end of the talk. So again, as I told before, I thank the Devaraj Medical College for taking this initiative on molecular aspect. I will be concentrating on breast. You all know this is the histology, we see it in breast cancers, and slowly it is going to take over by the molecular. And let us see what is the changes in molecular, how there is a smooth transaction from the morphology to molecular pathology. So our objective in the next 40 minutes is we will just have some brief introduction and then problems in the current situation. When we need a better technology, there should be a problem in the current technology, isn't it? So what are all the problems in morphological? This window is not closing. Sorry, just 1 minute. Seeing this window, it's not closing. Just 1 minute. Yes. So how long the breast cancer was there? As long as there have been breasts. And I don't know how many of you can read Latin. If you can read Latin, I will give you a few minutes for you to read. Otherwise, you please believe me. This is a 4.68 meter long paper that describing 48 surgical cases in the year 3000 BC. And at least 8 breast cases have been documented there. Among them, one was almost certainly the breast tumor, the 45th case. That's what it's written in this window. So the breast cancer is there for a long time. And what is the current situation? We follow the morphological classification. You can see in the background, WHO 2019 has come up with a new classification system. And after classifying the tumor, we histologically grade them and we do basic IHC, ERPR, and HER2/neu. And then we do the TNM staging, both the clinical and the pathological staging. So what is the current problem? They are all very highly subjective. Okay. So for example, the Nottingham grade, if you check your own records, grade 2 will be more because people, they always love to stay in the middle berth when there is a 3-tier system. And they are not accurate. And over treatment is happening in the low risk diseases and under treatment is happening in the high risk diseases. So in a nutshell, it's like a bag of marbles and different marbles are there in the same bag. Okay, they may look alike, but the outcome is different. So this picture will show you, we don't know which is the cat and which is the tiger. They are all in the same bag. For example, when you say grade 2 infiltrating mammary carcinoma NST, we don't know who need chemotherapy and who need 10 years hormone therapy, who will recur, we don't know. So that's the current situation. So similar features, but different outcome. What we want similar features to have similar outcome. Then only we can manage these cases nicely. And the need is divergent depending upon the low risk cancers and the high risk cancers. For low risk cancers, we have management challenges, and high risk cancers, we have innovation challenges. In the low risk cancers, we have to carefully select the patients for the management, for the chemotherapy, for the hormone therapy, and we have to monitor the side effects. And in the low risk cancers, we have to avoid chemotherapy as much as possible. Whereas in the high risk cancer, again, we should have a better selection tools to select the people who are at high risk. And then we have to identify the subsets of subsets. And we should have a lot of therapeutic innovations because these are high risk cancers that are not responding to normal treatment. So therapeutic innovation is needed in high risk cancers. And slowly we have to turn all the high risk cancers into low risk cancers by doing screening, genetic studies, preventive studies, lifestyle and risk reduction, education, and better models of care. So these are all the needs. And the molecular classification is very helpful in addressing these needs. I'm not saying 100% it will satisfy, but at least 90% it will fulfill our current needs. So to start with, very basically, how to do the molecular studies. I'm starting very basic stuff. We are all made up of, the human body is made up of cells, and cells are having a cell membrane or cell border. And then they have cytoplasm, and then they have the nucleus. In the nucleus, we have the chromosome. Chromosome is made up of bases, DNA bases, and the message in the DNA are converted to, or passed on through the messenger RNA to the ribosomes to make the chain of amino acids. And these chains of amino acids are assembled into proteins. And these are all the proteins that are responsible for cancer development. So this is the basic stuff: cell membrane, cytoplasm, nucleus, chromosome, DNA, RNA, amino acid chains, and proteins. So when we read what's happening in the chromosome, we call it karyotyping. When we check the DNA and RNA, we call that science as genomics. And when we check the transcription happening in the ribosomes, we call it as transcriptomics. And when we talk about proteins and their metabolic products, we call it proteomics and metabolomics. These are all the multiple omics that are very helpful in molecular, and you will be hearing more and more throughout the day about this. So you be comfortable with the terminologies: genomics, reading about DNA and RNA; transcriptomics, talking about the transcription; and proteomics is the end product, proteomics and metabolomics. Everything in breast cancer started with the beautiful paper from Dr. Peru, Professor Peru, in 2000, published in Nature, and a lot of changes are happening. I am giving good number of references in the internet. I kindly request all of you to make a note of it, because every minute there are a lot of changes happening in the molecular pathology, and major research advances for breast cancer by ASCO, American Society of Clinical Oncologists, are available in this website, cancerprogress.net. What Professor Peru has done, he selected 40 cases, and he checked for 1,753 genes, 496 intrinsic genes in 8,102 microarrays. And then you subtyped the findings by hierarchical clustering. This is just to tell you what he did. He took the cancer cells and he took the normal cells, isolated the RNAs, made the mRNA, and then made the complementary DNA. These are flagged with red fluorescence, whereas the normal cells, same thing as done, and they are given green fluorescence. And they looked for the targets in a combined way, and they hybridized it to microarray. Okay, and when you see that microarray, clustering happened. When I show this one, you may be able to remember. One cluster of cases, they have products related with genes related to cytokeratin 7, 8, 18, and 19. Another cluster had a cytokeratin 5, 6, 14, 15, and 17. Another cluster had HER2 new. And the other one, it had a gene profile very similar to normal breast control. So there were majorly, there was 4 clusters happened. The cases that had cytokeratin 7, 8, 18, 19, they had high ER, no HER2 new. And interestingly, they have a low P53 and a low Ki67. Another cluster in the same subcluster in the same cluster had a low ER, higher HER2 new. So remember, the HER2 new started coming, and then they also had high P53 and high Ki67. The cluster of cases that had CK5, 6, 14, 15, 17, they are negative for ER, negative for PR, negative for HER2 new, but they are positive for EGFR, P53, Ki67 was high, and they showed c-KIT. The 4th cluster in his group showed a HER2 enriched, ERPR negative, androgen receptor positive. They also had high P53 and Ki67. Now, when they check the cells, you all know there is a luminal cells and basal cells in breast. The cells that are having a high ER, they belonged to luminal A type of cells, whereas low ER and high HER2 expression and Ki67, they may fall in the luminal B. Please remember, in luminal B, we have both ERPR and HER2 new. Whereas in the cluster that had a negative for ERPR HER2 new, that belonged to basal cell type. And HER2 rich type, as the name indicates, HER2 is positive and ERPR is negative. And the cluster that had a genetic profile similar to normal breast control is now we know it as normal, because as you remember, this is a microarray. They cannot see the tumor cells. That's one disadvantage of doing microarray. What they submitted as tumor, it had only normal. So based upon these findings, they classified breast cancer into 5 main types: normal breast-like cancers, luminal A, luminal B, HER2 positive, and basal-like. This is the basic molecular classification of breast cancer. But then they all know this normal breast-like cancer, there is no cancer in the tissue submitted. It's a normal tissue. So they removed that. So that left us with 4 types of cancers. As I told, normal gene expression similar to normal control. So they removed that type from the molecular classification. And then in the basal type, there is again a lot of heterogeneity in that. Triple negative and basal-like, they are overlapping. Histologically, it can be ductal, medullary, adenoid, cystic, or metaplastic, but all triple negative are not basal. I will elaborate it further down. So the whatever Professor Peru has done in microarray, they try to recapitulate in the IHC-based technology. So let us see what are all the types of cancer by IHC-based technology. It can be luminal, it can be HER2-neu, or it can be triple negative. And further, it is divided depending upon the Ki67 and PR into further types. Okay, it can be luminal A, luminal B, which is usually Ki67 high, more than 14%, and progesterone receptor less than 20%. And they can also have HER2. The HER2-neu tumors can have luminal or pure HER2 enriched. The luminal type will have progesterone receptors. And then triple negative. In the triple negative, it can be basal-like or non-classified breast carcinoma. There are 2 types in the triple negative. And this typing is done mainly by doing ER, PR, HER2-neu, Ki67, CK5, and EGFR. CK5 and EGFR are the markers for the basal cells. So let us start with a non-classified type. Everything is negative. Okay, even the basal cell markers are negative. This belongs to triple negative because ERPR HER2-neu positive, and basal cell markers are also negative. Sorry, all the ERPR HER2-neu negative and basal markers are also negative. Okay, so they are the non-classified breast carcinoma. Ki67 can be any number. Whereas in basal-like breast carcinoma, the CK5 and EGFR will be positive and all the ERPR HER2-neu will be negative. This is the true basal-like triple negative breast cancer because the basal markers are positive. Coming to HER2 enriched type, here ERPR negative, HER2 positive, any Ki67 number, and the basal markers are negative. Only HER2 is positive. So these are 3 very easy types of breast cancer in the molecular classification. Coming to luminal A, the ERPR positive, HER2-neu negative, and usually it is a low Ki67, low proliferating tumor. Whereas when you come to luminal B, there are 2 types. In one type, it is a high Ki67 and a high progesterone receptors. Whereas in the other type, the progesterone receptor will be less in number. Coming to HER2 enriched type, it can be positive along with ERPR, or it can show only HER2-neu with any number of PR cells. The difference between the HER2-neu pure type and the luminal type is the ERPR is also expressed in these HER2 positive tumors. That you have to remember. I kindly request all of you to take a snap of this because this table nicely tells the molecular classification of the breast cancer. If you want to take a selfie with this, you are more than welcome. If you have any questions, please note it down and I will try to answer it at the end. So life is not that simple. Okay. there is a group called Molecular Taxonomy of Breast Cancer International Consortium, Metabric. Okay, they did gene expression profile in 2000 breast cancers, and they came up with 10 integrative clusters. What do you mean by that? We know the classification is molecular classification is luminal A, luminal B, HER2, and basal-like. In the luminal A itself, some patients are doing better and some patients are not doing that good. That's why the Metabric study, they classified, or they want to know what is happening in luminal A, and they have clustered the cases. For example, the luminal A, as I told you before, there are 10 clusters. Luminal A has 2, 3, 4, 6, 7, 8, and 2 is associated with poor, 3 is with good, 6 is with intermediate, 7 and 8 with good prognosis. So if you see here, this itself is a bag where they have good prognosis tumor, intermediate prognosis, and poor prognosis tumors in the luminal A. That's why people are now going with this Metabric clustering, because this tells the prognostic group. Okay, usually the histology of luminal A tumors are tubular carcinoma or low-grade mammary carcinomas or infiltrating lobular carcinomas, classic type. But they themselves are having a heterogeneous group of tumors. Luminal B also has heterogeneous group, whereas HER2 is uniformly poor. And basal-like, again, they have two groups, one associated with poor prognosis and other one associated with good prognosis. So this Metabric clustering of 1 to 10 tells more about the prognosis. So what are the treatment options currently? Surgery, radiation, hormone therapy, chemotherapy, and targeted therapy. And we take the tumor stage, Nottingham grade, margin status, lymph node involvement, and metastasis to decide on these things. But the main question is to give or not to give chemotherapy in low-grade cancers. And what patients can we give the targeted therapy? And the molecular profiling of breast cancer will answer these two very important questions. These are very important because when you put the molecular type, the luminal A and B sensitivity of chemotherapy is minority, whereas in the basal-like it is majority. The p-value is very significant, statistically significant. That's why we have to classify the low-risk patients who are eligible for chemotherapy and who don't need chemotherapy. And with the experience so far, this is the table that tells you what are all the treatment recommendations. For luminal A, it is endocrine therapy for up to 10 years, 5 to 10 years. For luminal B, HER2 negative, it is chemotherapy and endocrine therapy. For luminal B with HER2 positive, it is anti-HER2 is also included in that, along with the chemotherapy and the endocrine therapy. For HER2 positive non-luminal type, the endocrine therapy is not given because it's a non-luminal type. Whereas in triple negative, they are giving chemotherapy and they are going for targeted therapy. So to answer who should get the chemotherapy, there are some calculators and risk stratifiers available. The calculators, they calculate the risk depending upon the statistics. Oops, what happened? Pradeep, can you see my screen?
Sir, I can see your desktop, sir, now, not the PowerPoint present, not the keynote presentation.
The sharing has stopped, I think. Just, I will again go back and come.
PG na ಕಳಿರಿ ಯಾರಾದ್ರೂ PG ನ ಕರೀರಿ PG
Sir, your Zoom is already on, sir, because you're able to see your desktop. Keynote, you'll have to reopen it, sir. Yes, sir, we are able to see it. Sir, you'll have to unmute, sir.
Can you hear me now?
Yes, sir, I can hear you, sir.
Yeah. Sorry for that glitch. So to answer the question, who should get the chemotherapy? There are calculators and risk stratifiers, as I mentioned. The calculators, they work on the statistics available in the literature, and the risk stratifiers, they work on the molecular. Adjuvant online, St. Gallen's criteria, and gene expression signatures, there are few models. Let us see a few of them. In the adjuvant online, this is available online, and you have to fill up some factors about the patient. For example, age, comorbid condition, ER status, tumor grade, tumor size, positive or negative for nodes. And you can calculate either the mortality or need for chemotherapy. You can 10-year risk, you can calculate. Okay. And then hormone therapy, what hormone you want to give, chemotherapy, what chemotherapy you want to give. And when you put all the data needed, and when you click the submit button, then you can get the results. Okay, in this case, no additional therapy is needed. With the hormonal therapy, the benefit is 0.3%. With the chemotherapy, again, it's very low. With the combined therapy, it is 0.5. So they may not need any additional therapy. And these are all calculated by the statistics available in the literature. St. Gallen's calculator, again, you have to fill up all the data, and it gives a low risk, intermediate risk, and high risk. And it will help you to select whether to give chemotherapy or hormone therapy. Now, let us focus on the topic of the day, molecular techniques in breast cancer. There are 5 main applications for molecular techniques. One is diagnostic application, other one is prognostic, third one is the new word you all know, theranostic, okay, response to therapy prediction. And fourth one is in the identification of novel targets, and fifth one is to understand the biology. These are all the 5 basic applications of molecular technology in breast cancer. Let us see one by one. And the techniques used are IHC, next generation sequencing. You all know the name is being changed into multiple parallel sequencing, because next generation, how long will you be calling it as next generation? We are done. Okay. So it is MPS, and then multi-omics. Remember the omics we talked about, genomics, transcriptomics, proteomics, metabolomics, that is used in molecular technology. Digital pathology and AI-based algorithms, nanotechnology and nano-drug delivery, and liquid biopsy. These are all the 5 techniques used to address the diagnosis, prognosis, theranosis, identification of normal targets, and understanding of biology in breast cancer. In the molecular methods, there are 3 approaches: top-down approach, bottom-up approach, and candidate gene. What do you mean by that? In top-down approach, you take the clinical outcome, select the people who are doing very good, and then see what is the pattern in that good prognosis group. So this is clinically driven, coming to biology. Whereas in the bottom-up approach, subclassify by biological hypothesis. Okay. And for example, what is the pattern in the metastatic tumors? So this is biology is driving the clinical outcome. And the last one is candidate gene. Okay. What is the effect of a particular gene? For example, P53, we all know. What is the outcome of tumors with P53 mutation? So these are all the 3 approaches that are used in molecular methods in breast cancer. In the diagnostic application, that's number 1, they are very helpful in diagnosis of special tumors, and in the differential diagnosis of DEH, ADH, and low-grade DCIS, carcinoma of unknown primary. It plays a very vital role in carcinoma of unknown primary. They have a role in spindle cell lesions also, grading of phyllodes tumor, diagnosing, confirming Paget disease, and the vascular invasion. I know we are mainly going to talk about breast carcinoma. I just want to give some additional on the spindle cell lesions. For example, myofibroblastoma, they are associated with the deletion or monosomy of 13q and 16q. Fibromatosis, you all know beta-catenin expression mutation, and it involves the CTNNB1 pathway. Nodular fasciitis and DFSP, they are associated with the translocations. Inflammatory myofibroblastic tumor, you can see the ALK rearrangement, and for sclerosing epithelial fibrosarcoma, you can see MAC4 expression. So I won't be talking about spindle cell lesions hereafter. This is like buy one, get one free. Coming back to the diagnosis of special tumors, you all know these are all the new special tumors present in the WHO 2019: secretory carcinoma, adenoid cystic carcinoma, mucoepidermoid, pleomorphic adenoma, polymorphous adenocarcinoma, acinar cell carcinoma, tall cell carcinoma with reverse polarity, and adenomyoepithelioma. And if you see these, they are more or less associated with the salivary gland. And you all know breast is a modified sebaceous gland, isn't it? So that's why the salivary gland tumors can also happen in the breast. They are all having very classic molecular changes. For example, secretory carcinoma, translocation 12-15, that has a marker, pan-track marker, and TRK inhibitors can be used in these tumors. Adenoid cystic carcinoma has MYB, mucoepidermoid translocation level 19. Pleomorphic adenoma has a pleomorphic adenoma associated gene 1 and HMGA2. Polymorphous adenocarcinoma has a PRKD1 and 2 or 3 rearrangements. Acinar cell carcinoma, this is a minor change. All these, the same molecular events are seen in the salivary gland also. Whereas in acinar cell carcinoma in breast, it shows only TP53. What is the new marker now in salivary gland, which is a NR4A3, that's negative in acinar cell carcinoma of the breast. We don't know why. The new entity included in 2019 WHO, tall cell carcinoma with reverse polarity, has a IDH2, and you may be hearing from Vani madam more about IDH2, but that also has a role in tall cell carcinoma with reverse polarity. And in adenomyoepithelioma, it has HRAS Q61 hot spot mutation. Let us see some pictures. And before going to the pictures, these are all triple negative cancers. And remember, in the triple negative itself, there is one cluster in the metabolic study, low grade, good prognosis and bad prognosis. So these are all the tumors that fall in good prognostic triple negative. That's why they are called low grade triple negative breast cancers. This is a beautiful example of secretory carcinoma. In the breast, thyroid-like tumors can happen. When you see follicular thyroid-like lesion, then it is secretory carcinoma. When you see papillary-like lesion, it is a tall cell papillary carcinoma with reverse polarity. I will show it to you in a minute. But here you can see a lot of secretions that will be PAS-D positive. And the pan-track marker is a nuclear marker that can be assessed by IHC, or the translocation 12-15 can be seen by FISH. This is a classic adenoid cystic carcinoma, and it can be positive for nuclear marker MYB. Mucoepidermoid carcinoma, you can see nice mucin and hybrid cells and squamoid cells that will be nicely nuclear positivity for MAML2. This is the tall cell carcinoma with reverse polarity. Imagine if you say this is from thyroid, you will diagnose papillary carcinoma of thyroid. Okay, when you see papillary carcinoma of thyroid in breast, it is tall cell carcinoma with reverse polarity, and that will have cytoplasmic IDH2 R172 because there's a hotspot mutation in that site. Coming to acinar cell carcinoma, the classic marker for salivary gland is negative in breast, but they will be all positive for P53. Adenomyoepithelioma, you can see the carcinoma cells as well as myoepithelioma cells with vacuolated cytoplasm. So this is a classic adenomyoepithelioma that will be positive for HRAS in the membranous as well as in the cytoplasmic pattern. So molecular studies are very helpful in the diagnosis of special types of breast cancer. Coming to the prognostic application, you know there is a prognosis in the molecular classification. In addition to that, it helps in the stratification of ER positive, HER2 negative, node negative cancers, because these patients who are ER positive, HER2 negative, and node negative, they don't need chemotherapy. So how to stratify these patients? There are some IHC based assays and there are some RNA based assays. The IHC based assays are IHC 4, Mammostrat, Pro XTM BR, EXGen BC. And in the RNA based assays, Oncotype DX, MammaPrint, Breast Cancer Index, PAM50, ProSigma, and the EndoPredict. These are all the common tests that are available in the market. Let us see one by one. And all these markers, both IHC and RNA-based techniques, they answer these three questions. They will tell what is the risk of the recurrence of cancer. They will tell whether the patient needs chemotherapy or not. And they will tell the hormone therapy to be given for 5 years or more than 5 years. These are all the three very important prognostic questions that will be answered by the molecular findings. So in the IHC-based assays, we have IHC4 score, and they look for the 4 genes. And the positive thing is we can use the formalin-fixed paraffin-embedded tissue for this. They look for ERPR, HER2, neu, and Ki67. The results are given into low, intermediate, and high. And the clinical utility, they predict the recurrence-free survival and the chemo. But one drawback here, when it is low or high, no problem. But when it is intermediate, we don't know what to do. So whenever you are preferring some test over the other, go for the 2-tier test. I hate the 3-tier system because the second tier is nothing. It is a bag of tier 1 and tier 2. Okay, so go for 2-tier system. In the Insight Mammostrat, they use 5 genes. Again, paraffin embedded tissues can be used. Again, 3 grades. They also talk about risk of recurrence, whether they need endocrine therapy and chemotherapy. In the prognostic application, most of them are microarray and RT-PCR based. One disadvantage here, we don't see the tumor. Whereas in IHC based technique, we see the tumor. In microarray, we don't see the tumors. And when you are submitting the tissue, you make sure a parallel tissue is submitted for the H&E to confirm the presence of tumor. Otherwise, we will end it up what was initially done as a normal pattern, because normal cells may be mistaken for cancer. Normal tissue can be mistaken for tumor. So selection of tissue is very, very important when you are submitting for any microarray, and you have to take parallel tissue to run on H&U to confirm the cancer presence. Okay. Oncotype DX is the most common PCR based, reverse PCR based test. Again, here we can use now the technology has improved, you can use the paraffin embedded tissue. They look for 21 genes, 16 cancer related genes and 5 controls. Again, you see here 3-tier system. Okay, not very good. And they talk about benefit of chemotherapy and what is the recurrence rate in hormone therapy. And they are very useful in ER positive, HER2 negative, node negative patients. Okay, and these are all the genes they look for, and these are available in the internet. And I am not going to go through what are all the genes they are looking in all these tests. Okay, they may be related to estrogen receptor, progesterone receptor, HER2 neu, proliferation, invasion, or others. Okay. We had recently we had a case. It's a 49-year-old female with 1.3 centimeter right lower quadrant mass, and they did the core biopsy. Blue is bad. You can see the tumor dark blue colored, more than 70% of the volume. This is the low power that sorry. This is the low power that you can, sorry for my antiviral thing is making a big, I will just quit the note. Cells arranged in a lobular pattern, targetoid pattern, and in the high power also you can see the perineural Surup, can you see the screen and can you hear me?
Yes, sir, I can.
Super. So here you can see the nice perineural invasion. So nice perineural invasion you can see. And we do these panels, ER positive, PR positive, HER2 negative, Ki67 is moderate, we gave 18%. And in addition to that, we do the marker for EGFR. And because the true basal type will be EGFR positive, here you can see the nice control of the normal breast epithelium, whereas the tumor cells are EGFR negative. And our clinicians want androgen receptors also. So the androgen receptors are positive in this case. So ER positive, PR positive, HER2 negative, Ki67 18%, AR positive, and EGFR positive. Swaroop, do you see the message from Norton antivirus in your screen?
Yes, sir. Yes, sir, we do. So can you drag it to one of the corners, sir?
Yeah, I'll do that. Is it all right now?
Yes, sir. It's all right.
Super. So we gave it as a invasive mammary carcinoma with the lobular features, Nottingham histological grade 2. And after doing immunohistochemistry, this is ER positive, PR positive, HER2 negative, Ki67 18%, EGFR negative, androgen receptor positive. So we gave the diagnosis of luminal B type of cancer with the Ki67 more than 14%. But the patient underwent modified radical mastectomy, and it's a PT1C M0 invasive carcinoma, and margins are uninvolved. The question here is whether to give chemotherapy or not. So they have sent this case for oncotype DX. This is the result of oncotype DX. The recurrence score is 14. The low risk is 18, high risk is 18 to 30, and intermediate risk, and the high risk is more than 31. So luckily, our patient had fall under low risk group, okay, not in the intermediate group. And they also mentioned the distance recurrence risk at 9 years is 4%, and the group average absolute chemotherapy benefit is less than 1%. That means no need to give the chemotherapy. And I made so many calls. This patient is affordable, and unfortunately, these tests are very costly, 3.5 lakhs. But I took a lot of pain to find out who is doing that. So I thought I will just put this one, MedLeader Laboratories Private Limited. Praveena was kind enough to help us in sending this a tumor for the oncotype DX, and it is done only in Memorial Sloan Kettering Hospital in US. So I don't have any financial connections, but I thought I will give you the details. So if you come across any affordable patients and when the clinicians are needing any molecular test, Praveena can help you. Just to tell you this availability. And again, unfortunately, I don't have any financial connections. So the next test is MammaPrint. Okay, again, it can be done by microarray or formalin fixed paraffin embedded tissue. Here they check for 70 genes. And here the result come as low risk and high risk. Luckily, there is no intermediate risk in this group. And they estimate the recurrence rate. Okay, and these are all the 50 genes that they look for the MammaPrint studies. The next is endopredict. This is again, they can do RT-PCR or paraffin embedded. And whenever they do it in paraffin embedded tissue, you please give the paraffin embedded tissue. They are looking for 11 genes, and they talk about distant and late recurrence. These are all the genes they look in endopredict. The next one is Prosigna or PAM50. Okay, they look for 50 cancer related. Again, the results are low, intermediate, high. I don't like it. These are all the 50 genes they look in this PAM50. Breast onco PX and Celera metastatic score, they talk about risk of metastasis. So that's all about prognostic stratifications. Now we are coming to response to therapy prediction, which is very, very important because some patients respond to hormone therapy initially and then they develop resistance. Some patients develop resistance to chemotherapy also. So these are all the four helpful features. One is Foundation 1 CDX. CDX means companion diagnostic approved by FDA. Second is resistance to hormone therapy. Whenever there is a resistance to hormone therapy, there are three pathways you have to remember: FAT1 hippo pathway, MAP kinase, and APOBEC mutagenesis. And third one is BRCA-NES. BRCA-NES is very sensitive for platinum-based therapy. Okay, again, tests are available to say that. And finally, they do liquid biopsies where they look for estrogen receptor 1 mutation. Those patients develop resistance to hormone therapy. Okay, this is the example of Foundation 1. They look for 324 genes and 2 genomic signatures, and this covers all the solid tumors. In the breast, they look for HER2 and PIK3CA, and because they have medicines against them, that's why they look for them. So this is the sample of the Foundation 1 diagnosis. Okay, here in this tumor, PIK3CA positive, and so they can give this medicine. I'm not pronouncing these names of the medicines because they are all tongue twisters. Coming to identification of normal targets, what are all the targets? Hormone receptors, HER2, BRCA, immunotherapy, and antivascular. Okay, in the hormone receptors, we know about tamoxifen, aromatase inhibitors, and the new targets are mTOR inhibitor, PI3K inhibitor, and anti-CDK1, CDK4, and anti-CDK6 inhibitors. Okay, and in HER2 new positive, you know, anti-HER2 antibodies and anti-dimerization and TK inhibitors can be used as a target for HER2 positive patients. BRCA mutated, this is a new marker that comes helps in BRCA mutated patients, which is PARP1 and 2 inhibitors. Immunotherapy, you all know anti-PD-L1, and in the lung molecular pathology, they will be covering more about anti-PD-L1. And antivascular, again, this is anti-VEGF antibody. So these are all the novel targets identifiable by the molecular techniques. Sorry for this Norton virus, it is killing me. So the last one is understanding the breast cancer biology. Okay, so by doing this molecular test, we came to know the luminal A is showing more PIK3CA mutation. Like that, each type is having one type of mutation. They help in the subtypes of lobular carcinoma, and they also help in the inter and intra-tumor heterogeneity. Okay, for example, there is a test called wound response signature. Okay, and they do mainly by microarray. They look for 442 genes associated with the wound response. They give two categories of answers, and they mainly indicate poor clinical outcome. The next one is immune signature, where they look into 14 genes and they predict the relapse in anti-HER2 treated patients. The last one is invasiveness gene signature, where they check the 186 genes that are associated with the invasion. Okay, and they talk about 10-year distance metastasis-free survival in node-negative patients. So there are so many genes they are looking in so many types of tests, but how to know what genes to be tested? Some basic information. You all know there are 4 sources to get these genes. One is Human Genome Project. Okay, you all know we have a complete, our genome is mapped completely by the second one is, so first one is Human Genome Project. Second one is the Cancer Genome Atlas, TCGA, and they have a pan-cancer atlas. They know what are all the genes involved in breast cancer. So you can select the gene from that project. And the third one is from the Sanger Institute. understanding the breast cancer. Okay, they also talk about a lot of genes involved in cancer. And fourth one is Human Proteome Project. These are all the main sources that tells you what gene to look. And all these panels are marketed by the scientific people who work on these particular genes. Okay, so what are the pitfalls of molecular techniques? Fresh frozen tissue, whenever you are using, you have to be careful with the sampling error. They are not reproducible 100%. Please believe me, nothing is reproducible by 100%. Still some overlap exists, but definitely less when compared to molecular typing. And host response is not considered because everybody responds differently. But slowly some studies are coming to address the host response also. And the last factor is the cost. Okay, the minimum test cost is 3.5 lakhs. Okay, but please remember, more and more patients are affordable. When they become affordable, more and more people do, the test become less costly. So what is the conclusion? Molecular profiling of breast cancer, from the morphological typing, it will go in for molecular classification. This is what you will be doing it in your future. The second one is they enhance the understanding of the biology, they refine the classification, and they improve the management by guiding ER positive, lymph node negative, low group patients from the ER negative patients. And the lastly, you have to integrate all the reports. You have to integrate the H&E findings, IHC findings, and the molecular findings in one report, because in addition to be a good pathologist, we should train ourselves as a good fortune tellers with the help of molecular technology. And these are the 4 awesome references. One is from New England Journal of Medicine, second from Modern Pathology, third is from Seminars in Cancer Biology, and the fourth one is from Molecular Classification of Breast Cancer. So these are the references. I kindly request you, if you are more interested, please look into these references. And I want to end it up. Molecular pathology is future. Please first you learn it and then remove the L from it. Thanks a million and have a nice day. Sorry for the technical glitches with that Norton antivirus. Over to you, Swaroop.
So thank you, sir. If there are any questions, the participants can raise their hands. So there are a few questions in the chat box.
Yes.
One is regarding the role of PDL1 in breast carcinoma.
Yes, PDL1 is going to play a major role in all cancers, because you know what is the basic stuff in PDL. They stop our T cells responding to tumor cells. So by blocking it, we are activating our tumor T cells against the tumor cells. So in one line, PD1 and PDL1, they deal with the T cells, and when they are present, they inactivate the T cells. So we want our T cells to be active. So we give the PD1 and anti-PDL1 to activate the T cells. And the complication is, by activating T cells, you are increasing our immune system. So many autoimmune diseases may come as a side effect in those patients. But it's very well done in lung, but other organs also catching up. Next question, Swaroop.
So difference between luminal A and luminal B with respect to progesterone receptor is not clear.
Yes, that is very correct. But you take this factor as a thing to differentiate A and B. A is Ki67 low, rich in ER and PR, whereas luminal B is Ki67 high. In addition to progesterone receptor, they can have HER2 nu also. and you have to remember that number 20, and you remember that table that will help you to differentiate luminal PR low, PR high, and luminal PR plus HER2 positive. Okay, Swarup.
So what is your experience about VEGF in breast cancer?
Again, as you know, VEGF is the neoangiogenesis. By blocking the neoangiogenesis, we are making the cells deprived of blood supply, and we are thinking they will die of lack of blood supply. Again, these are all very experimental. I don't have any personal experience in breast cancer. It is coming up in the breast cancer. They are using it whenever other treatments are failing, they are using it, but they are not first drug of choice.
All the tests like MammaPrint are used for ER positive cases, but BRCA is triple negative.
No, you can't use BRCA MammaPrint. MammaPrint, as I told, indications are there. Most of the prognostic stratifiers are used ER positive, HER2 negative, means BRCA negative, node negative patients to give chemotherapy or not. It should not be used for BRCA, but again depends upon the clinician and patient. Okay, when they ask for it, I am not in a position to say no, but they are very useful in low risk or low grade breast cancers rather than HER2 In HER2 you have to look for novel treatment targets, which is point number 4. Remember the diagnostic application, the application, molecular application. 1 is diagnosis, 2 is prognosis, 3 is theranosis, 4 is novel targets, and 5th one is understanding biology. For BRCA, it is more 3 and 4. Okay, response to treatment and novel targets rather than prognostic stratifiers. They are already in a poor prognostic group. Thank you, Swarup.
So last question, sir. Types of basal-like cells.
Don't understand. Types of basal-like cell means either histologically there is only one basal cell, but molecularly they are thinking basal-like cells are triple negative, and they should express basal markers like EGFR. But when they are triple negative and not expressing EGFR, they are basal-like cells, or now they are called as non-classified cells. So the basal cells are again only one type, triple negative, EGFR positive. Thank you, Swarup. Swarup, are you there?
Thank you, sir. So thank you, sir.
Thank you, sir, for your simplified and insightful lecture on molecular pathology of breast tumor. And for the second session, we have with us Dr. Vani Santosh, Professor, Department of Neuropathology, NIMHANS, Bengaluru, who will be talking on molecular pathology of gliomas. I request Dr. M.L. Harendra Kumar, sir, Professor of Pathology and IQAC, Coordinator, to introduce the speaker.
Good morning to one and all. I'm happy to introduce the Dr. Vani Santosh, one of the renowned neuropathologists. And currently she is serving as a professor of neuropathology and associate dean of neuroscience NIMHANS. And she has been the coordinator of the prestigious neurobiology research center at NIMHANS for several years. And she has established the neuro-oncology laboratory at the center. And she is a resource neuropathologist for various conferences, CME and symposium. And she has delivered more than 200 invited lectures in India and abroad. She is the recipient of the Teacher of the Year Award for postgraduate teaching program in India. She has a special research interest in the field of neuro-oncology and spearheaded several brain tumor research projects to uncover novel biomarkers and drug targets. And this led her to initiate molecular diagnostic service for brain tumors in neuro-oncology laboratory which is now offered as a routine service. She has authored over 200 publications in index journals and 20 chapters in various books. She is a reviewer for many journals. She has contributed to a chapter in the 2016 and the upcoming 2021 editions of the WHO classification of tumors of the nervous system. And she's one of the editors of the recently published Essentials of Diagnostic Neuropathology. She has 4 patents to her credit and is involved in several projects funded by Government of India. And she also delivered some prestigious orations in the country, such as Balasubramanian Oration at the Institute of Neurology, Madras Medical College in 2009, Dr. M. Parsarthi and A.V. Prasad Oration at the 34th National Annual CME Pathology at KLE University in 2011, and Kochi Neurological Society Oration at the Annual Conference Neurological Society of India, Kerala Chapter 2015, Tamil Nadu Puducherry Oration at 56th Annual Conference of the Indian Association of Pathologists and Microbiologists, Jaipur in 2016, and also the President Oration, Karnataka Neuroscience Academy at Bagalkot, and President Oration, Indian Society of Neuro-Oncology at New Delhi in April 2018. She has also been elected Fellow of National Academy of Medical Sciences and also Fellow of the Indian College of Pathologists. And she is a reviewer for many pathology journals like Cancer Biology, Neurology journals, including Clinical Cancer Research, Journal of Clinical Pathology, Child's Nervous System, Annals of Translational Medicine, and Scientific Reports, Translational Cancer Research, Neurology India, and others. She has also served as president of the Karnataka Neurosciences Academy and Indian Society of Neuro-Oncology. Now I welcome Dr. Vani Santosh to deliver. Over to Dr. Vani Santosh.
Thank you very much. I hope all of you can hear me.
Yes, ma'am.
Yeah, thank you. So thank you for that kind words of introduction. I'll start sharing my screen and yeah. Are you able to see my screen?
Yes, ma'am, we are able to see your screen.
And I'm audible as well, right?
Yes, ma'am.
So let's start. And first of all, I'd like to thank Dr. Suresh and the organizers of the Devaraj Medical College for inviting me to take part in this online CME program. Certainly a great pleasure for me to be a part of this symposium. And I think the timing is apt for a molecular pathology CME on tumors because, as Dr. Rajendran already said, this is the way forward, and all the moleculars are going to be incorporated into the subsequent classifications, including that of the CNS tumor. So today I'll give you an overview of molecular pathology of gliomas. He asked me to talk about all the CNS tumors, but I think that is going to take me more than 3 to 4 hours to talk about the different CNS tumors. So I selected gliomas because this is the most common primary brain tumor, both in the adults as well as in the pediatric age group. But before I really delve into this molecular pathology, just a brief recapitulation of the evolution of the CNS tumor classification itself. And you should know that the very first classification was proposed way back in 1926 by Bailey and Cushing. And this was based on the then existing knowledge on the histogenesis and the ontogeny of the brain tumors. Subsequently came these WHO classifications from 1979 to 2007. And in these 4 editions, the classification was based solely on the histomorphology of the tumors. But post 2007, we know that there has been an explosion of the molecular data from which have evolved a growing number of molecular biomarkers. And many of these biomarkers were incorporated in the ISN Haarlem guidelines. This is the International Society of Neuropathology guidelines that was proposed in this place called Haarlem in Netherlands. In the year 2014, this has been published in Brain Pathology. I'm sure many of you have gone through this publication, where they proposed a layered or an integrated diagnosis where you layer both histology as well as the molecular parameters. And this was subsequently incorporated in the revised 4th edition of the WHO, that is the WHO 2016 classification that we are currently following, that displays a combination of morphology and genetics. But we do know that our knowledge on molecular genetics is ever expanding. And to keep in pace with it, updates such as the C impact now, I'll come to this a little later, have been published post 2016 classification, and they serve as vehicles to connect this revised 4th edition with the upcoming 5th edition of the classification, that is the WHO 2021 classification that we are soon expecting to be published. And this classification moves further in advancing the role of molecular diagnostics in CNS tumor classification. Nevertheless, it is deeply rooted to the classical approaches of tumor characterizations such as histology and IHC. And so what we are expecting is a hybrid taxonomy, but the one that has matured significantly from the 4th edition. Now, this graph shows you the timelines where some of the major molecules in the brain tumors were identified, starting with the 1p19q in the mid-90s, then came the INI, the IDH, the ATRX, the C19MC, histone alterations, RELA fusion, and so many more molecular alterations that we are now very aware of. If you go back and look at the traditional classification of gliomas, they've been classified into two broad groups, the diffuse and the non-diffuse. Diffuse, that includes these lower grade gliomas of grade 2 and grade 3. These are the astrocytomas, oligodendrogliomas, and oligoastrocytomas that all of you are familiar with. And glioblastoma, which is WHO grade 4. The non-diffuse included the circumscribed gliomas such as the pilocytic astrocytoma, PXA, SEGA, and other tumors, and ependymoma, as well as a group of other gliomas which had all these astroblastoma, chordate glioma, angiocentric glioma. So this was the traditional classification of the gliomas. I'll start with the diffuse lower grade gliomas because these are the most common primary brain tumors that we encounter in the adults. They represent a prototype example of a group of tumors where there has been a paradigm shift in classification from histopathological to molecularly defined entities. And the three clinically relevant molecular biomarkers that all of us are so familiar with now, that is the 1p19q co-deletion, the IDH mutations, ATRX mutations, they have been used to generate a molecular diagnostic algorithm in WHO 2016 that is found to be superior to the classical histopathological entities, and we'll look at that. A brief note on these molecular markers. The first is the 1p19q co-deletion that occurs as a result of unbalanced translocation between the short arm of the chromosome 1, the long arm of the chromosome 19, with the loss of the derivative chromosome, which is 1p and 19q. The best way to test this in clinical neuropathology is by the FISH technique because we can do it on the FFPE sections. We use two probes, one is for the 1p and one is for the 19q. And this is a retained status where you have two green and two orange signals. The green is the control, the orange is the test signal. When you have either one orange against two green or no orange signals in more than 40% of the tumor cells, or the green to the orange to the green ratio is less than 0.8, then you consider this as a deleted status. Now, 1p19q co-deletions has been associated, there has been proved to be a prognostic and predictive biomarker, particularly in oligodendroglioma, starting with the early studies by Kane Cross and colleagues who showed that it was associated with improved survival in anaplastic oligodendroglioma patients and a predictor for sensitivity to chemotherapy. Now, apart from its role as a prognostic and a predictive biomarker in oligodendrogliomas, it has entered the diagnostic armamentarium and is essential for the diagnosis of oligodendroglioma grade 2 and grade 3 as per this classification. The next gene is IDH, which is isocitrate dehydrogenase. This is an enzyme that plays a very important role in the Krebs cycle. There are three isoforms, IDH 1, 2, and 3. One is in the cytosol, 2 and 3 are in the mitochondria. Basically, it catalyzes the oxidative carboxylation of isocitrate to alpha ketoglutarate, increasing the NADPH levels and providing cellular protection to the glial cells against oxidative damage. Once there is a mutation, the alpha ketoglutarate level falls and NADPH level falls. There is increased susceptibility of the glial cells to the oxidative stress, releasing hypoxic molecules such as the HIF1 alpha, which along with its downstream targets is known to be pro-tumorigenic. On the other hand, there is also production of an oncometabolite, which is known as the 2-hydroxyglutarate or the 2-HG. which is known to be associated with risk for glioma development. Basically, it has a profound effect on the cellular epigenomic states as well as in gene regulation. What it does is it inhibits two groups of enzymes, the TET or the 10-11 translocases, and the Jumonji group of demethylases, and induces a DNA hypermethylation or a histone hypermethylation status. And Dr. Rajendran spoke to you about the TCGA, that is the Cancer Genomic Atlas. This is also done in the CNS tumors. And their epigenomic data earlier had led to the discovery of what is known as the GSIMP status, which is the glioma CPJ island methylator phenotype status, which includes a signature which comprises hypermethylation of 7 gene loci and hypomethylation of 1 gene locus. And these diffuse lower grade gliomas, regardless of them being an astrocytoma or an oligodendroglioma, if the GSIMP status is high, they're associated with a good clinical outcome. And if it is low, it is associated with a poor clinical outcome. And now we know that mutant IDH has a mechanistic link with this GSIMP phenotype. Interestingly, these IDH mutations was initially identified by Parsons and colleagues way back in 2008 when they carried out integrated genomic analysis on a set of human glioblastoma tumors. They found recurring mutations in the hotspot of the IDH gene in about 12% of the cases. They got interested in these tumors. They went back and looked at the profile of the patients, only to realize that all of them were the progressive glioblastomas, that is, they progressed from grade 2 to grade 3 and then to the grade 4. This evoked a lot of interest in several other research groups, and many researchers have now shown that IDH mutations is the earliest mutational alteration that happens in diffuse gliomagenesis, and therefore it's found in high frequency in diffuse lower grade glioma of any of the phenotypes, say astrocytoma, oligo or oligoastrocytoma, and progressive gliomas, including secondary glioblastoma, but not in primary de novo glioblastoma. Now, both IDH1 and IDH2 mutations are known to be associated with gliomas, and predominantly it is IDH1 that is seen in more than 95% of the cases. And among the IDH1 mutations, the most common is the heterozygous PONT mutation, where arginine gets replaced by histidine in position 132 of the amino acid sequence. This is known as the canonical IDH1 mutation, seen in more than 93%. Other IDH1 mutations are known, like the R132C, S, G, L, and V. And IDH2 mutations are rare. They account for only 5% of all these gliomas. And the most common position that is involved is the amino acid position 172. And the commonest mutation is the R172K mutation. Now, this is known as the canonical IDH mutation, and all other IDH mutations and IDH2 are the non-canonical. The way we detect the canonical mutation is by IHC, because there is a monoclonal antibody that is raised against IDH1 R132H, and I'm sure most of you are using it in your routine practice. It has a great diagnostic value because it is positive in diffuse gliomas of any of the phenotypes. You can differentiate them from the circumscribed gliomas, ependymomas, the glioneural tumors, and even reactive gliosis, which is always negative for IDH1 R132H. All other IDH1 mutations and the IDH2 mutations cannot be detected by IHC, and we go ahead to do the DNA sequencing for these mutations. Now, the next alteration is ATRX, which is alpha thalassemia mental retardation syndrome X-linked mutation. This is a regulator of the chromatin remodeling and transcription, and the way it acts is that it forms an ATP-dependent complex with another transcription factor, which is known as the death domain associated protein. Now, this complex, it deposits the H3.3 on the histone tail of the DNA, and it stabilizes this histone's tail, and thereby bringing about the gene expression. Now, mutation of this ATRX is known to induce an abnormal lengthening of the telomeric length through a mechanism known as the alternative lengthening of the telomere, which is mutually exclusive with the TERT promoter mutation, because we know that TERT promoter mutation can also bring about this lengthening of the telomere, but you should remember that the ATRX is always mutually exclusive with TERT promoter, and both of them do not occur in the same tumor. ATRX mutations was initially identified in the neuroendocrine tumors of the pancreas, the neuroblastoma, osteosarcoma, and subsequently detected in diffuse progressive astrocytomas of these grades. But now we know that they're also associated with histone mutant gliomas. So when you see ATRX mutation, it's just not in the IDH mutant tumors, but also in the histone mutant gliomas. The detection is by immunohistochemistry because a monoclonal antibody is raised against this ATRX protein. It's a nuclear stain, and you look for loss of nuclear expression for the mutation status because it's a truncating mutation. And some of the cells that are normally present within the parenchyma, such as the endothelial cells, the overrun glial cells, the neurons or lymphocytes, are all positively stained, and they serve as a positive internal control for you to assess the loss of expression in the tumor cells. And this is mutually exclusive with 1p19q co-deleted oligodendrogliomas, where you see a retained ATRX expression. So remember, in astrocytomas, you see loss of expression. In oligodendrogliomas, you see retained expression. Now, TP53 mutations are also known to be present in high frequencies in diffuse gliomas. And most of these are missense mutations, and that results in a nuclear accumulation of the p53 protein. But let me tell you that p53-IHC is neither sensitive nor specific to the TP53 mutation. But when we find that there is a diffuse strong immunopositivity, these are the mutated tumors, and this immunopositivity is shown to tightly correlate with the loss of ATRX expression. So when you see loss of expression, you will always see p53 immunopositivity in majority of the cases, although not in all the cases. So what are the key markers that we use routinely for the characterization of adult diffuse gliomas, grade 2 and grade 3 with established technologies? Let me stress on histology. Histology is the cornerstone, and this provides the background for you to ask for all these markers. If your histological impression is wrong, then interpretation of the markers also will go wrong. So remember, histology still plays the cornerstone. The other markers are IDH, ATRX, P53, MIB1 or the Ki67, which is a nice adjunct for you to grade your tumors, as well as 1p19q. And what are the technical platforms for the IDH1, R132H, ATRX and P53? It is the simple IHC. For the rare IDH1 and 2 mutations, you do DNA sequencing and 1p19q by the FISH technique. A word of caution over here, that when you have ATRX loss of expression P53, in case this is negative for IDH1 R132H, you cannot take it as a surrogate and assume there was some rare mutation, because now we know that they're also associated with histone mutated gliomas, and it's important to carry out the sequencing to identify the rare IDH1 and 2 mutations. So based on all these molecular markers, the WHO 2016 classification has proposed this algorithm for the approach to the classification of diffuse gliomas. All of us are very familiar with this algorithm. The first, it has 3 tiers. The first is histology, where the tumor is either glioblastoma or a lower grade glioma of any of the phenotypes, say astrocytoma, oligodendroglioma, oligoastrocytoma. The second is the IDH status. In both the groups, you'll have a IDH mutant and a wild type subgroup. And in the lower grade gliomas, there's a third tier, that is the 1p19q and other genetic parameters like the ATRX and the p53. Using this algorithm, one can identify the specific histomolecular subgroup of the diffuse glioma, say for example, diffuse astrocytoma, IDH mutant, oligodendroglioma, IDH mutant, 1p19q co-deleted, or glioblastoma, that is IDH mutant or wild type. And of course, there is the provision for this NOS, or the not otherwise specified entity, that implies that the necessary genetic testing was either not performed or the results are inconclusive. So this table shows you the comparison of the 2016 WHO classification of gliomas when compared to 2007. I told you that up to 2007, they were based only on histomorphological features. So in 2007, the classification is histologically defined, and we have all astrocytic tumors that are clubbed together. That is the circumscribed astrocytomas, the diffuse astrocytomas of the different grades. Then came the oligos, the oligoastrocytic tumors. But now in the 2016 classification, you can see that all these diffuse gliomas come under one header, that is the diffuse astrocytic and oligodendroglial tumors, that encompasses all the molecular subgroups that you can see here. And the circumscribed astrocytomas have been put under this other group, which is the other astrocytic tumors. So basically, as per the WHO 2016 classification, the diagnosis of oligo or anaplastic oligodendroglioma mandatorily requires the demonstration of IDH mutation 1p19q co-deletion, in the absence of which we call it as NOS. Now, as you know, this is classical oligodendroglioma. You're all aware of the histology. It's positive for IDH1 R132H, so it is IDH mutated. ATRX is retained. I told you oligos have retained status, astros have lost status. So this is ATRX that is retained and P53 is negative, 1p19q is co-deleted. So the diagnosis you're going to offer is oligodendroglioma, IDH mutant, 1p19q co-deleted, WHO grade 2. In case you cannot do some of these tests, then you call it oligodendroglioma. Oligodendroglioma, WHO grade 2, NOS. So that is what you're going to call this. What about the diffuse and anaplastic astrocytomas? Now they are also divided into these groups: IDH mutant, which is more common, IDH wild type, that is uncommon, and of course there is the NOS entity. For example, this is anaplastic astrocytoma. You can see the cellularity, the anaplasia, the frequent mitosis, no microvascular proliferation necrosis. This is positive for IDH1 R132H, so it's IDH mutated. ATRX shows loss of expression and P53 is diffusely positive. When you have a profile like this on IHC, you call it as anaplastic astrocytoma, IDH mutant, WHO grade 3. And when you have this IHC profile, further 1p19q testing is really not required as per the guidelines of the C Impact Now update 2 that I'm going to talk about, as well as our own Indian Society of Neuro-Oncology consensus guidelines, where we put proposed a practical adaptation of this classification to reduce costs for individual patients. However, if the tumor is negative with this scenario, if it is negative for IDH1 R132H, then sequencing will be required to determine whether it is an IDH mutant or a wild type tumor. So what happens to this entity, oligoastrocytomas? They become obsolete because if molecular testing is performed, they're either molecularly defined astrocytomas or molecularly defined oligodendrogliomas. And when you do not have facility for this, then you call it as histological, not otherwise specified. That will be your diagnosis. So IDH mutations are seen in 100% of oligodendrogliomas, grade 2, grade 3. So remember that there are no IDH wild type oligodendrogliomas. All of them are IDH mutant. It's the defining molecular parameter for oligo. What about astros? It is seen in about 80% of WHO grade 2, grade 3 astrocytomas and 8 to 10% of GBMs, which we call as secondary GBMs or IDH mutant GBMs. And many of these studies, including our own previous study, has shown that IDH mutations are associated with a favorable prognosis, but the concept is changing over a period of time, and we'll discuss that as well. What about these IDH wild type astrocytomas? Because it's only astrocytic tumors that can be wild type. They account for about 20% of the astrocytomas, although in our own series, we are seeing a lower percentage of such IDH wild type astrocytomas. They're a set of aggressive lower grade astrocytomas. They look like grade 2 and grade 3 histologically, but in essence, several behave like glioblastoma itself. Let us look at some example. This is one of our patients, a 35-year-old male, diagnosed as anaplastic astrocytoma on histology. This was IDH wild type, both on IHC as well as on sequencing, and it progressed very rapidly to recur as glioblastoma within 5 months of this initial diagnosis. In fact, Roos and colleagues from the German group have used integrated genomic approach, and they have shown that IDH wild type lower grade astrocytomas, they actually biologically resolve into the molecular subgroups of glioblastoma itself. They look like lower grade, but they behave like glioblastoma. However, that concept is changing over a period of time, and new studies have shown that not all IDH wild type lower grade astrocytomas are aggressive in their behavior. It's only a subset that is aggressive. And this is the very large study from Vanden Bent's group, where they have shown that the only subset of IDH wild type astrocytoma with aggressive behavior have GBM-like molecular alterations, such as EGFR amplification, gain of chromosome 7, loss of chromosome 10, or TERT promoter mutation. And it is only this subset that is associated with a poor prognosis, not all IDH wild type lower grade astrocytomas. What about IDH mutant astrocytomas? I told you a couple of slides back that they're all associated with a favorable prognosis, but even that concept is changing. And new studies have identified a subset of rapidly progressing IDH mutant astrocytomas as well. And some genetic markers that are associated with rapid progression have been identified, such as the CDKN2AB homozygous deletion, amplification of CDK4, PDGFRA, NMYC amplification, and a low GSIMP levels. Now, the one that has been validated in prospective cohorts and is a very robust marker for rapid progression is the CDKN2AB homozygous deletion.
Now, what is CDKN2AB? This is cyclin-dependent kinase inhibitor 2A and 2B. Both the genes are located very closely on this 9p21.3 locus. Whilst the CDKN2A encodes for P16 and P14, the CDKN2AB encodes for P15. And all these are tumor suppressor genes. They act by inactivating the CDK4 and 6, or they prevent the P53 degradation. So they act as tumor suppressors. But once there is a deletion, the tumor suppressor action is gone, and that would result in uncontrolled activation of the genes involved in transition from G1 to S phase. And several studies, starting with the initial study by Dr. Ari Perry's group, and many more studies have shown that CDKN2AB loss in IDH mutant lower grade astrocytomas is associated with a shorter overall survival. Taking all this into consideration, very recently, Takashi Komori from Japan, neuropathologist, he has put forth this schematic diagram for grading IDH mutant lower grade astrocytomas, taking into consideration not only histology, but the genetic parameters. If you take histology into consideration, there is grade 2, grade 3, grade 4. Grade 2 are the less cellular ones, paucicellular tumors with mild nuclear atypia. Grade 3 has mitosis and anaplasia. And grade 4, as we know, is the IDH mutant glioblastoma currently. And these tumors have necrosis and microvascular proliferation. But if you take genetic alterations, the most important being the CDKN2AB deletion, that's why it is in larger and bolder fonts. Any tumor, whether it is of grade 2, grade 3, or grade 4, if it harbors this deletion, it's associated with it conforms to WHO grade 4, associated with a worse clinical outcome. It has a lower DNA methylation levels and a higher genomic instability. So what is the frequency of this CDKN2AB deletion in lower grade as IDH mutant astrocytoma? It's approximately 0 to 12% in grade 2 tumors, 6 to 20% in grade 3 tumors, and about 16 to 36% in grade 4 tumors. How do we assess this? This is by the FISH technique. We have a probe on 9p21.3 locus, and it covers about 190 kilobases, which encompasses both the CDKN2A, 2B, along with another gene known as the MTAP gene. So we use only that probe. And against the CEP9, which is the centromere alpha satellite sequences of the chromosome 9. So the green is the CEP9 and the orange is the CDKN2AB. If you find 2 green, 2 orange in the interface nuclei, then it is considered as retained status. If there are 2 green, 1 orange, then it is hemizygous deletion. But if there is 2 green and no orange signal, then it is homozygous deletion. And this is the one that is considered for prognosis. Now, what is the cutoff for you to call a tumor as homozygous deletion? Now, very recently, the cutoff that has been mentioned is equal to or more than 30% of these tumor cell nuclei. So what have we been seeing post 2016 classification? There has been an increasing impact of molecular approaches, definitely. And that necessitates a series of changes to the future CNS tumor classifications. And that has been addressed by the C-Impact now, which is the consortium to inform molecular and practical approaches to CNS tumor taxonomy. Although it was formed by the core group of the WHO, now stands for not officially WHO because it is not an official WHO process. It was started in 2017. It was announced in this year, sponsored by International Society of the Neuropathology. Now, the goal of the consortium has been to facilitate the input of various molecular data, to review them, to see how much are diagnostically relevant and to incorporate them into the future CNS tumor classification. And 7 updates have been published between 2018 and 2020. They serve as vehicles or guidelines for the next classification. And I'll discuss all the first 6 updates. The last one is on ependymoma, which I'm not going to cover in this lecture. The first 6 updates that are relevant to this lecture. In the very first update, the C-Impact defined 2 terminologies. I think this is important for you. Not otherwise specified and not elsewhere classified. Not otherwise specified implies that the necessary molecular diagnostic evaluations were not performed or the results are inconclusive. For example, you have an oligodendroglioma and you are very sure of the morphology. It's a WHO grade 2. You have performed IDH ATRX, but you were not able to perform 1p19q. Then you call it oligodendroglioma grade 2 NOS. Now, NEC or not elsewhere classified implies that the necessary assays were all performed, The results were available to you, but they don't allow for a specific diagnosis. So there is a mismatch between histology as well as the moleculars. For example, you have the same oligodendroglioma. It is IDH positive, R132H positive, but it is 1p19q non-co-deleted. But you're sure that the morphological features are oligo, WHO grade 2, then you can call it as an NEC entity. The C-impact now update 2, it provides diagnostic clarification for diffuse midline glioma H3K27M mutant. I'll come to this a little later. And diffuse and anaplastic astrocytoma IDH mutant, and they state that these IDH mutant diffuse astrocytomas that show loss of ATRX expression, strong diffuse p53 immunopositivity, then a diagnosis of diffuse or anaplastic astrocytoma IDH mutant can be rendered in the absence of 1p19q testing. And that is exactly what we had proposed a couple of years ago in our Indian Society of Neuro-Oncology consensus guidelines. Now, we were looking at IDH wild type and IDH mutant astrocytomas. Now, we know that only a subset of IDH wild type astrocytoma that harbor these mutations have a poor prognosis. And this has been now, this is a recommended diagnostic criteria by the C-impact now update 3, which states that in these IDH wild type diffuse astrocytic glioma, only those tumors that harbor these GBM-like molecular alterations like EGFR amplification, gain of chromosome 7, loss of chromosome 10 or third promoter mutation should be referred to as diffuse astrocytic glioma IDH wild type with molecular features of glioblastoma WHO grade 4. And this is the only subset that is associated with a very aggressive behavior. Now, the C-impact 5, it provides grading criteria and terminology for IDH mutant astrocytoma because now we know the importance of this molecular marker. This is very interesting. Now, the IDH mutant astrocytomas are graded as grade 2, grade 3, and grade 4. Note that the terms diffuse astrocytoma for grade 2, anaplastic astrocytoma for grade 3, and IDH mutant glioblastoma have been removed. And for grading, the Roman numerals have been replaced by the Arabic numerals. Why is that? Because all the terminology is the same in all the 3 grades, and the Roman numerals can cause some sort of a transcriptional error. So as per this, IDH mutant astrocytoma grade 2 are well differentiated tumors with no or mild anaplesia. They have nil or low mitosis. There is no microvascular proliferation necrosis, and they do not harbor CDK and 2AB deletion. IDH mutant astrocytoma grade 3, which we used to call as anaplastic astrocytomas, these are the tumors with significant anaplesia and mitosis. Note that there is no cutoff that has been mentioned for the mitosis. It is just significant mitosis. It can be a little subjective. No microvascular proliferation or necrosis, and no evidence of CDK and 2AB deletion. An IDH mutant astrocytoma grade 4 will replace the term IDH mutant glioblastoma. These are the tumors that have microvascular proliferation necrosis or CDK and 2AB homozygous deletion or a combination of these features. So the tumor can look like this, but if it has CDK and 2AB homozygous deletion, then it will conform to WHO grade 4. And that highlights the grading and the prognostic power of this particular biomarker. So that was the grade 2, grade 3 tumors. We'll move on to glioblastoma because we know that this is the most malignant, unfortunately the commonest of the adult diffuse gliomas. They are diffusely spreading in the parenchyma. These are the butterfly gliomas that go from one hemisphere to the other across the corpus callosum. There are areas of necrosis within the tumor. Histologically, there can be a varied picture that you can see with spindle-shaped cells, undifferentiated cells, pleomorphic cells, lipidized cells, epithelioid-like cells, or even a sarcomatous pattern. But what characterizes the tumor is florid microvascular proliferation, which is in the form of these glomeruloid tufts, as well as necrosis that can be palisading or confluent, which is usually associated with the sclerosed and thrombosed blood vessels. IDH mutations had provided a new look to these tumors, and the WHO 2016 classification has categorized this as IDH wild type and mutant glioblastomas. IDH wild type glioblastoma, it corresponds to the erstwhile primary glioblastoma, accounts for the large majority of the cases, that is 90% of the cases. They're seen in older individuals, shorter duration of symptoms, and a poorer prognosis. Mutant glioblastoma corresponds to the erstwhile secondary glioblastoma. These are IDH mutant tumors. They are progressive tumors. They occur in younger individuals, longer duration of symptoms, and a better prognosis. And whilst the mutant glioblastomas are somewhat circumscribed, mainly located in the frontal lobe. The wild type tumors can be located anywhere in the supratentorial compartment. If you look at their underlying molecular alterations, whilst the wild type tumors harbor mutations such as the TERT promoter mutation, EGFR, or the PTEN mutations, the IDH mutants are enriched by TP53 as well as the ATRX mutations that we are very aware of. And now, as per the guidelines of the C-Impact Now Update 5, the IDH mutant glioblastoma terminology itself is going to be removed. It will be replaced by IDH mutant astrocytoma grade 4, and that would enforce the association of these tumors with the continuum of the IDH mutant astrocytomas and differentiate them from the classical glioblastoma, which is only IDH wild type. So when we are talking about glioblastoma in the older individuals, we are talking only about the IDH wild type tumors. Now, these IDH wild type glioblastomas can harbor a myriad of molecular alterations. And one of the most frequently altered genes is EGFR. And the amplification is seen in about 50% of the cases. You can detect this by the FISH technique. And 20 to 50% of the amplified tumors are known to harbor EGFR V3 mutations. One other alteration that we see is the TERT promoter mutation. TERT is a gene on chromosome 5p15, encodes for this telomerase reverse transcriptase, the catalytic subunit of which maintains the telomeric length. And with respect to IDH wild type glioblastomas, it is seen in more than 75% of the cases. But mind you, it is noted in more than 95% of oligodendrogliomas. And paradoxically, whilst it's associated with a poor prognosis in glioblastomas, it's associated with a favorable prognosis in oligodendrogliomas. Mutations occurs at two hotspot regions of the codon, that is the position 228 and the position 250, the more common one being the 228 position. So now the latest C-Impact Now Update 6 actually defines glioblastoma IDH wild type and states that this is an IDH wild type diffuse astrocytic glioma with any of these features: microvascular proliferation, necrosis, or one or more of these molecular features that I've already defined. So if you have a tumor with any of these features, then you have to call it as glioblastoma IDH wild type. One of the prognostic and predictive biomarkers that we always study in association with glioblastoma is the MGMT promoter methylation. I hope there are some radiation oncologists on this forum who know the importance of MGMT promoter methylation. MGMT is O6-methylguanine methyltransferase, which is a predictive biomarker to the action of an alkylating agent, that is temozolomide, which is the drug of choice for glioblastoma. Basically, the way temozolomide acts is that it removes the alkyl groups from the O6 position of the guanine of the tumor cell DNA, breaks the cross strands, and results in the cell death. Now, MGMT encodes for a DNA repair protein, which removes alkyl groups from the O6 position of the guanine and makes it unavailable for action by temozolomide, thereby rendering the tumor chemoresistant. In the landmark study by Hagi and colleagues, they showed that epigenetic silencing of MGMT by the promoter methylation, it renders tumor cells sensitive to the alkylating agents. But many of you clinicians may ask me that, is it really required to do on a routine basis? The answer is no. Because MGMT promoter methylation, it really does not have a role in determining the administration of radiochemotherapy as a routine standard of care treatment. However, it's very useful in the recurrent setting as well as in the elderly patient when you want to modulate the dose of radiation as well as the chemotherapeutic agent. Glioblastomas, we know that they occur mainly in the older individuals, but they can occur in pediatric and young adults. It accounts for about 3% of all the pediatric brain tumors, 16 to 18% in the young adults. And interestingly, even though they are morphologically similar to the glioblastoma in the older adults, they're molecularly distinctly different from the tumors of the older adults. And more interesting is the fact that there is site-specific differences in molecular alteration in this age group. For example, the GBM that is located in the cerebral hemisphere has a molecular makeup different from that in the brainstem or in the midline. However, if you look at their molecular pathology of the pediatric young adult GBM, I will call it high-grade glioma because the molecular alterations of grade 3 and grade 4 in these tumors is always similar. And the key discovery that best illustrates this unique biology is the somatic histone mutations involving these two histone coding genes, that is the H3F3A, Hist1, H3B genes that encode for his H3 variants, that is 3.3 and 3.1, leading to amino acid substitution in two key residues of the histone tail, the K27M and the G34R. And these are biologically distinct tumors. And several large high throughput studies have shown that they have molecularly stratified the pediatric young adult high-grade gliomas into 4 molecular subgroups. The histone mutated group, this will have 2 subgroups, H3K27 mutated midline tumors or the G34 mutated hemispheric tumors. IDH mutant group, this is very rare in pediatric but common in the young adults. The BRAF mutant group and the H3 IDH wild type group. What entered the WHO 2016 classification is the diffuse midline glioma H3K27M mutant, which occurs due to mutations of H3.3 or 3.1 histones. And the C-Impact Now Update 2 provided diagnostic clarification for these tumors and stated that these tumors should be diffuse, not circumscribed. They should be infiltrating gliomas occurring in the midline defined as the thalamus, the brainstem, and the spinal cord. And they should harbor this H3K27M mutation. Luckily, we can detect it by IHC, where you see a strong nuclear staining. The tumor can have morphology of grade 2 or grade 3 in this region, but if it shows K27M immunopositivity, then you call it corresponds to WHO grade 4. And this terminology should not be used for tumors outside of the midline. For example, a subset of ependymomas, pilocytic astrocytomas, or even gangliogliomas can come positive, but those are not the diffuse midline gliomas. What about the G34R and V mutant? This is the next group. It is an emerging entity. It will come in the next classification. These are not in the midline. They are in the cerebral hemispheres. They occur in the adolescent and the young adults. And histologically, they can have a GBM-like, typical GBM-like pattern, sometimes pleomorphic cells, sometimes ganglioid-like astrocytes. And sometimes they can have this peanut-like features, very primitive neuronal features. Very characteristic on IHC will be that they're OLIC2 negative. Most of the diffuse gliomas are OLIC2 positive, whereas this will be OLIC2 negative. They will show ATRX loss and P53 immunoreactivity. So mind you, when there is ATRX loss and P53, they're not just the IDH mutant tumors, they can also be the histone mutant tumors. For example, this is one of our cases where you can see ATRX loss of expression, P53 positivity, and on sequencing, it shows the mutation in the H3F3A gene. They can also have co-occurring mutations. For example, the G34R can harbor all these mutations like the P53, ATRX, and others. The K27M, which is in the thalamus, can have similar mutations like this. But the one in the brainstem, we used to call this as the diffuse intrinsic pontine gliomas. They harbor other mutations like the ACVR, OLIG1, and OLIG2 mutations. So how does this H3K27 mutations act? Basically, either through canonical histone variants, that is 3.1 and 3.2, or non-canonical, which is 3.3. It brings about loss of this H3K27 trimethylated protein. So how does that happen? That happens because of an inhibitory interaction between this H3K27 mutation, and there is another molecule known as the EZH2, which is the enhancer of Zeast homolog 2, which is a methyl transferase catalytic subunit of the polycomb repressive complex 2, or the PRC2. Now, this inhibitory interaction between H3K27 and EZH2 drives the negative effect and brings about loss of H3K27 trimethylated protein. But is it always required to have this mutation to have this loss of H3K27 trimethylated? I'm sure you know that there are subsets of MPNSTs and other tumors that can show H3K27 ME3 loss without H3K27 mutant. So here in brain tumors, even H3 wild type tumors, they can harbor another protein known as EZH inhibitory protein, which is an endogenous mimic of the H3K27. That can also inhibit the PRC2 complex, bringing about loss of the trimethylated protein and driving oncogenesis by the transcriptional dysregulation. So what we are going to see in the 2021 classification is that this term diffuse midline glioma H3K27M mutant will be now replaced by the term diffuse midline glioma H3K27 altered, because the pathogenic pathway can be altered by different mechanisms. We know about epithelioid glioblastoma, which is a variant that was introduced in WHO 2016 classification, tumor occurring in the younger population. And these are all IDH wild type tumors, and more than 50% harbor the BRAF V600E mutation. Histologically, they have this characteristic pattern with these epithelioid cells arranged in sheets, and they show a very significant perivascular arrangement or an angiocentric arrangement, somewhat resembling ependymomas. They are variably GFAP positive, and those that harbor the mutation, you can identify by IHC because there is a monoclonal antibody for it, and it will be diffuse and strong cytoplasmic positivity. We are all histopathologists, and we want to make it as simple as possible. We want to know how to approach these tumors. So you have a diffuse glioma grade 2, grade 3, which is hemispheric. I'll start with immunohistochemistry with IDH1, R132H, ATRX, and P53. There are two scenarios. The tumor is IDH1, R132H positive, and ATRX is lost. P53 is positive. We know that these are astrocytic. So we have no problem with that, but we don't stop short at that. We have to do the CDKN2AB deletion because it will upgrade the tumor if there is a deletion. Now it is positive for IDH1, R132H, but it shows a retained ATRX status. P53 is negative. Then we know it goes towards the oligophenotype, and therefore you do the FISH, and when it is co-deleted, you call it oligodendroglioma. That is simple. Now it is negative for R132H. Then we have done ATRX and P53, but ATRX is not lost. It is retained. P53 can be plus or minus. So because this is retained, first we have to rule out oligo because the subset may harbor the rare mutations. So you do FISH. If it is co-deleted, you call it as oligodendroglioma. Then further sequencing is not required because we know that 100% of them have IDH mutations. It could be some rare mutation that could not be assessed by IHC. The problem comes if it is 1p19q non-co-deleted, and then it is IDH negative, ATRX is retained, P53 plus or minus, then there is a possibility you're missing a glioblastoma. You have to reassess histopathology for that. Now, what happens if it is negative and ATRX is lost, P53 is positive? We know it is astrocytic, but it could be a wild type tumor. So we have to do sequencing then. If it is mutant, you call it astrocytoma IDH mutant, then follow that with CDKN2AB deletion. If it is non-mutant, then you call it as wild type. So importance in these astrocytomas IDH mutations, mutant tumors is to carry out the CDKN2AB deletion by FISH because that would upgrade your tumor. Now we have this entity, IDH wild type. How do we then go about? It is IDH wild type both on IHC as well as on sequencing. You have to see whether it is hemispheric or in the midline. If it is hemispheric, if the patient's age is older, ATRX is not lost, it is intact, then you do this GBM-like molecular markers. If they come positive, then you need to label this tumor as GBM IDH wild type regardless of the grade on histology. But if it comes negative, you don't know where to fit it, you use the term NEC very comfortably. But if it is a younger patient and it is IDH wild type, ATRX is lost and P53 positive, we know that these can be associated with histone mutant glioma. So we have to do the sequencing for histone genes. And if that is positive, you call it as a histone altered hemispheric glioma. Now, if it is negative, then you have to go ahead and look at all other markers, BRAF and others. And if that is also negative, once again, come back and do this GBM-like alterations to see whether you can fit it into this group of tumors. What if it is in the midline? The first thing you have to do is H3K27M. If it is positive, rule out circumscribed tumors, make sure it is diffuse, and then you label it as diffuse midline glioma H3K27M mutant. But if it's negative, then you'll have to think of the other GBM markers. So these are the two approaches that you need to remember, and you need to apply that in your routine practice. And as Dr. Rajendran said, it is just not this IHC and the established technology. We've moved further. There are techniques like the high throughput DNA RNA sequencing, that is the transcriptome analysis, the nanostring encounter technique, the next gen sequencing, which he nicely called as the multiple parallel sequencing or the MPS, the DNA methylation profiling. In fact, DNA methylation profiling is now becoming increasingly important because the German group have shown they have actually formed, they have constructed an atlas where they have classified the tumors according to the methylation status. Now, finally, I'll move into the other astrocytomas, which are the pediatric low-grade tumors, and which we call as circumscribed. That includes pilocytic, the pylomyxoid, the PXA, the anaplastic PXA, as well as the subependymal giant cell astrocytoma. You know that the most common one is pilocytic astrocytoma, which is a WHO grade 1 tumor. These tumors occur in the children and the young adults, most often in the cerebellum, where they present as a cyst with the mural nodule complex, but they can occur anywhere else in the neuraxis, hypothalamus, optochiasmatic region, the optic nerve, which are associated with the neurofibromatosis type 1, and several other sites in the neuraxis where you can see pilocytic astrocytomas. We are very familiar with this histomorphology of pilocytic astrocytoma, which I don't have to describe. It has the classic biphasic pattern with the densely fibrillated areas having these Rosenthal fibers, the loose areas that have all these eosinophil granular bodies. And pylomyxoid astrocytomas was described as a variant corresponding to grade 2 in the WHO 2007 classification, but now that grade has been stripped off. There is no assigned grade. It's a tumor that occurs in very young children, mainly in the hypothalamic region. It is composed of a monomorphic population of pyloid cells that are embedded in a rich microcystic myxoid matrix, which show prominent angiocentric arrangement of the tumor cells. There is no Rosenthal fibers or eosinophil granular body, and currently it is considered to be a less mature pilocytic astrocytoma. What is the molecular pathology of these pilocytic astrocytomas? Many studies have shown that they're driven by molecular alterations in several genes that are enriched in this MAP kinase pathway or the mitogen activated protein kinase pathway. And is considered to be a single pathway disease. And the most frequent of these alterations in this pathway is the BRAF alteration, where there is a tandem duplication of chromosome 7. It is in the chromosome 734Q. And this BRAF gene, this particular locus, it harbors the BRAF oncogene, which brings about a fusion with another gene, which is known as the KIAA1549. For example, this is the box that represents the 7q34 position of the long arm of the chromosome 7. It has two important genes, the BRAF gene as well as another gene known as KIAA1549. Both of them read towards the centromere. Now, approximately about 2 MB of this gene, it is duplicated and then gets reinserted in the breakpoint, bringing about fusion between the 5' end of the KIAA1549 and the 3' end of the BRAF that code for the kinase. And this fusion brings about abrogation of the regulatory activity of the BRAF gene. So how do you test for this KIAA1549 BRAF fusion, which is the commonest alteration that we see? It is, you can do the FISH technique or real-time PCR. By FISH, normally a cell will have 2 green, 2 orange signals, but here you will find 2 green, 2 orange, and an extra signal, which is the fusion signal, which will be yellow in color. Now, mind you, it's just not the KIAA1549 BRAF fusion. It can have other BRAF fusions or even BRAF point mutations. Several other genes can be mutated in this pathway, including the NF1, the FGFR, the NTRK, and several other genes, which activate the genes, the downstream targets of this MAP kinase, such as the MEK, as well as the ERK, which is the extracellular signal regulating kinase, and that brings about activation of the transcription factors. This table shows you all the alterations of the various genes in this MAP kinase pathway in pilocytic astrocytomas. The most common is KIAA1549 BRAF. It can occur at several exon junctions between these two genes. Most common is the 16-9, followed by the 15-9 and the 16 level. But it is not just that. You can have other BRAF fusions. It can fuse with several of these genes. Then you can have several other alterations like KRAS, FGFR, NTRK, NF1, which can all alter this MAP kinase pathway. The most common, of course, is the KIAA1549 with the BRAF fusion, which is seen predominantly in the cerebellar tumors, but you can also see in the supratentorial tumors. I told you the other way to do it is by the real-time PCR. This is the work that is carried out by one of my previous DM students, where she analyzed about 61 cases. And we have seen this fusion in about 77% of the cases, and the large majority were in the cerebellum, and the most common exon junction alteration was between 16 and 9. Recently, there is another entity that is being described, that is the high-grade astrocytoma with pyloid features. If you remember, we used to call these as pilocytic astrocytoma with anaplastic features, atypical features, etc., etc. This occurs in older individuals. It's defined as an astrocytoma, which has histological features of anaplasia alongside a pyloid histology. So we can have eosinophil granular bodies, Rosenthal fibers, but the tumor will be malignant. And these tumors will show frequent MAP kinase pathway gene alterations, such as the NF1, followed by the BRAF or even the FGFR genes. Histologically, very characteristically, these tumors will show loss of ATRX nuclear expression. Alongside with this, there is homozygous deletion of CDKN2A and B. They have a distinct DNA methylation pattern. It occurs mainly in the older individuals, most often in the cerebellum and associated with a poor prognosis, and we are going to see it in the next classification. Now, pleomorphic xanthoastrocytoma is a very unique astrocytic tumor, occurs in the children's supratentorial, presents as a cyst with the mural nodule, corresponds to WHO grade 2. Well delineated tumors, these are very well delineated tumors. They have a rich reticulin stroma, and you know the histology. They have pleomorphic cells, they have xanthomatous cells, eosinophil granular bodies, tumor infiltrating lymphocytes. And the term anaplastic PXA corresponding to grade 3 was included in, this is an entity included in WHO 2016, defined as tumors with equal to or more than 5 mitosis in 10 hyperfields, with or without necrosis. So you need to call these tumors as anaplastic PXA. The most common molecular alteration is not the fusion, but here it is the BRAF V600E point mutation, which is a missense mutation occurring at the codon position 1799 in the exon 15 of the BRAF V600, BRAF gene, resulting in the replacement of valine by glutamate at position 600 of the amino acid sequence. Therefore, we call it as BRAF V600E mutation. And it is you can detect either by Sanger sequencing, and I also told you that there is an IHC marker for this. So in PXAs, the most common alteration is the BRAF V600E mutation, seen in about 60 to 80% of the cases, with CDKN2A homozygous deletion seen in 90 to 95% of the cases. In fact, in future, these two will become defining molecular alterations for PXA, and TERT promoter mutation, which occurs less common. Now, you know that BRAF V600E has a great utility in diagnostic, prognostic, as well as in the therapeutic role. Diagnostic, it is positive in PXAs, APXAs, epithelioid GBM, gangliogliomas, the DNETs or the dysembryoplastic neuroepithelial tumor, subset of pilocytic astrocytoma, papillary craniopharyngioma, a subset of rhabdoid meningiomas, and even in histiocytosis. And very recently, it has been shown to be present in some of these low-grade astrocytomas, as well as glioneuronal tumors and chordoid gliomas. Non-CNS tumors can be BRAF V600E positive, like the melanoma, papillary carcinoma of the thyroid, colorectal carcinoma, non-small cell lung carcinoma, and hairy cell. You're aware of all these. Its prognostic role is only in pilocytic astrocytomas, usually supratentorial tumor, and those that have the V600E mutation have a worse outcome than those with the fusion. Therapeutic role has been established because studies have shown a partial or complete response of BRAF mutated tumors to the BRAF kinase inhibitors, which is being used in routine practice. SEGA is subependymal giant cell astrocytoma. It is a WHO grade 1 tumor, occurs in the lateral ventricle, associated with this tuberous sclerosis complex because of the germline mutation of two tumor suppressor gene, that is the TSC1 and the TSC2. These are all the organs that can be involved in the tuberous sclerosis complex. 80 to 90% of SEGAs are associated with tuberous sclerosis complex. This is classical SEGA cell that I'm not going to describe. They're variably GFAP positive. And one other marker we use for SEGA is the TTF1. TTF1 is refining the diagnosis of several of the brain tumors, and this is positive in SEGAs. Basically, it drives the mTOR pathway. So when there is a biallelic inactivation of the TSC1 and 2 genes, there is loss of two tumor suppressor proteins, that is the tuberin and the hamartin, which activates this PI3 kinase AKT pathway, the downstream of which is mTOR, or the mammalian target of rapamycin. mTOR pathway activation is very important because mTOR inhibitors are now available clinically, and they're being used to reduce the volume of these tumors before surgeons take it up for surgery. Now, we know that in the pediatric age group, it is just not the circumscribed astrocytomas, but you can have diffuse gliomas also occurring in this age group. And so this is a very recent study by Cynthia Hawkins' group, where they combined all these pediatric low-grade gliomas in the era of the molecular diagnostics. This is the way they combined. It included all the circumscribed as well as the diffuse tumors. They also included glioneuronal because they have the same molecular alterations. And the large majority of these pediatric low-grade gliomas show alteration in the RAS and the MAP kinase pathway, which is seen in more than 90% of the cases. And the non-RAS MAP kinase pathway alterations are seen in only 10%. I've described this. It can be due to several genes upstream and the downstream, and that can result in the activation of the ERK. But what are these non-RAS MAP kinase pathway alterations? One is the MIB alterations, which are seen in angiocentric gliomas and diffuse astrocytoma, which can be MIB-QKI fusion or other MIB-L1 alterations, and IDH mutations. You can see it in a small subset of adolescent astrocytomas, and they're supposed to represent the lower end of the age spectrum of adult IDH1 mutant gliomas. So this is the list of the tumors and all the alterations. The large majority is MAP kinase and the small is the non-MAP kinase pathway. In fact, the C-Impact now update 4 have proposed a classification for pediatric type diffuse low-grade gliomas, which are IDH and H3 wild type tumors based on their molecular alterations. And most of them are associated with a favorable prognosis similar to that of the circumscribed astrocytomas. So we come back to C-Impact now. And because we know that all the recommendations will be included in the WHO 2021 classification. So what was not officially WHO will now become officially WHO and enter into this classification. So the last 2 slides are just a focus on this WHO, a preliminary focus or look at this 2021 classification. The focus of the classification is as follows. One is the CNS tumor taxonomy, which is going to be hybrid, as I already told you. However, the grouping of the tumors will be according to genetic changes, like the IDH mutated, the histone mutated status. We will have types and subtypes. In the previous classification, we used to have entities, variants, patterns, but now it is going to be types and subtypes. There'll be grades within types rather than each grade having a name. Let me give you an example. For example, in the 2016 classification, we saw that there is diffuse astrocytoma grade 2 IDH mutant, IDH wild type, NOS, then anaplastic astrocytoma. But now it's not going to be that. It will be IDH diffuse adult type gliomas will have the IDH mutant astrocytomas grade 2, 3, 4, IDH mutant 1p19q co-deleted oligos 2 and 3, and so on and so forth. The Arabic numerals will replace the Roman numerals for the grading. I told you the reason for it, and there'll be a combined histological and molecular grading. But what's going to happen in a lot of centers, including centers in our country, there is going to be a more generalized use of the NOS that is not otherwise specified and the NEC that is not elsewhere classified. And they suggest that you send it to higher centers for molecular testing. So this is how the 2021 classification is going to look like in comparison to 2016. 2016, among these diffuse tumors, we had almost 17 entities, but now we have adult type diffuse gliomas, which will have only 3, astrocytoma IDH mutant, oligodendroglioma IDH mutant 1p19q co-deleted, and GBM, which is only IDH wild type. So this will have its grades. Then in the pediatric type, high-grade gliomas will be defined by their histone status. Now in the pediatric type, we'll have diffuse low-grade gliomas as well as circumscribed tumors. We'll come back to circumscribed astrocytomas from other astrocytomas. And this will include all the tumors defined by their genetic alterations. So this will, of course, the histopathological features of each of these will be defined very, very clearly so that it will give you a hint to the pathologist as to which group it would belong to. So I think I'll conclude my session, and this is my conclusion remarks that molecular pathology is definitely reshaping our approach to diagnosis, for prognosis, as well as for therapy. But let me tell you that all classifications are imperfect representations, reflecting the state of understanding in a field at a particular time. Right now, we understand these genetic alterations, and they are going to be included in this classification. Nevertheless, they will provide a practical guidelines to the pathologists as well as specialists in neuro-oncology for their routine use. With that, I'd like to thank you for your attention, and I can take any questions.
Thank you, ma'am. If there are any questions, you can raise your hand. There's one question in the chat box, ma'am. What are the predictive markers in CNS and treatment associated with it?
So as of now, the predictive markers in CNS, if you look at the glioblastoma, which is a very high-grade tumor, we know that it is MGMT promoter methylation because MGMT promoter methylation is associated with prediction to action by the temozolomide therapy. And so the MGMT promoter methylation becomes very important. If you look at the low-grade gliomas, there are several therapeutic agents that are being used. Even as a first line, they're being used. For example, the BRAF altered tumors, the BRAF V600 mutated tumors can have all these anti-BRAF agents or the kinase agents that are being used in routine practice. So it is very predictive to that. And even the histone mutated tumors, there are new studies. I'm sure that there are a lot of studies or a lot of trials that are going on regarding the drugs against these histone mutated tumors. So these are all some of the molecular alterations that is going to reshape the therapy in future. Is there any other question? I don't know. One second.
There are no more questions, ma'am.
Thank you, ma'am, for your thought-provoking talk on molecular neuropathology and clarifying our concepts on gliomas, their mutations, approach, and introducing us to some emerging entities which will be added to the next edition of the WHO 2021. Thank you, ma'am. For the next session, we have Dr. Swarna Shivkumar, Senior Consultant, Histopathology and Cytology, Apollo Hospitals, Bengaluru. I now request Dr. T.N. Suresh, Sir, Professor of Pathology and MEU Convener, SDUMC, to introduce the speaker.
Good morning to all. I'm very happy to introduce my pathology mentor and a senior pathologist, Dr. Swarna Shivkumar. Madam has inspired me to take up this pathology post-graduation in 1995. I'm sure that she has inspired many more to enter into this noble profession. Dr. Swarna Shivkumar has completed her MD pathology in 1995 from JMC, Davangere. She started her career as a lecturer in a medical college in 1995. Since then, she served in various capacities and became professor and HOD at Adichinjuga Institute of Medical Sciences in 2007. She was actively involved in preparation of teaching material and established pathology museum in WIMS and AIMS Bellour. She has trained several batches of undergraduates and postgraduates in pathology. She was involved in administrative work and also headed the medical education unit at Vaidehi Institute of Medical Sciences. She has conducted many slide seminars and CMEs for postgraduate students. She also served as a guest speaker in many pathology conferences in Karnataka through KCPM. She has also conducted mortality meeting and various CPCs. She is a good academician, administrator, and her area of interest is lung pathology. That's what Madam is going to speak on this topic. And she is also interested in breast pathology with a special inclination towards oncopathology. She has more than 40 publications to her credit in various national and international journals. She also worked as a lab director from 2012 to 2014 at a reputed Apollo hospital for JCI and NABL accreditation. She is also involved in setting up digital pathology services at Apollo Hospital. Now I request Dr. Swarna Shivkumar Madam to talk on the molecular pathology of lung tumors. Over to you, Madam.
Yeah, thank you. Am I audible?
Yes, ma'am, you're audible.
Yeah. A very good morning to everybody. And I sincerely thank Dr. Suresh to introduce me for this session. And at the outset, I would like to thank the organizers for giving me this opportunity to talk on molecular pathology in lung cancer. This topic will be discussed and following headings like introduction, classification of lung cancers, molecular pathology of non-small cell lung carcinoma, morphology and immunohistochemistry, role of pathologist in molecular genetics, molecular testing, a tool for targeted therapy, then PD-L1 and immunotherapy in non-small cell lung carcinoma, and the last is conclusion. Moving on to introduction, as we all know that lung cancer is the leading cause of cancer-related deaths worldwide. Approximately about 1.8 million new cases are diagnosed every year.
Ma'am, will you share the screen, ma'am?
I'll just. Just a minute, Suresh. Is it okay? Is it seen now?
No, ma'am, it's not seen. No?
Just a minute, Suresh. Just call the comment.
Ma'am, you can just minimize your PowerPoint presentation and open the Zoom app, ma'am, and click share screen.
Hello. Hello.
Yes, ma'am.
Yeah, that Zoom, there is some problem with the Zoom. I think just another 2 minutes. Give me some 2 minutes.
Sure, ma'am, sure. We are able to see your video, ma'am. Aren't you able to see the share screen option, ma'am? What seems to be the problem? Ma'am, you have muted yourself.
No, I have to talk because it is not coming.
Sir, we're able to see your video and hear the audio, but we aren't able to see the PowerPoint screen. That you have to click share screen and choose PowerPoint.
Is it audible?
Yes, sir. Audio and video I'm able to see, sir, but not the PowerPoint screen. Only...
How about now?
Yes, sir. We are able to see, sir. You can go to presenters view, sir. Then.
Is it fine?
Yes, sir. It's fine. Yes.
Sorry for the inconvenience. Shall I start now?
Sure, ma'am. Yes, ma'am. You can go ahead.
So, as we all know that lung cancer is the leading cause of cancer-related deaths worldwide, and approximately 1.8 million new cases are diagnosed every year. Majority of the lung cancer are diagnosed in the late stage, even with the best available diagnostic modalities. Lung cancer has a relatively poor prognosis, where 5-year survival rate is 18%. A key discovery in the past decade has been that some lung cancers harbor specific mutations. This has promised to tailor a personalized therapy for the patients with lung cancer. Now let us move on to the classification. As it was discussed in the previous lecture, that the classification is mainly based on the molecular genetics in case of CNS tumors. Whereas though some of the lung cancers also harbor these specific mutations, but the WHO has not incorporated into the classification. So this classification is WHO is based on WHO 2015. Here in this session, I will be restricting myself to the malignant epithelial tumors of the lung cancer. So these are based on the cell of origin and the morphology. So that the lung cancer predominant group, it belongs to adenocarcinoma and its subtypes. Next comes squamous cell carcinoma and its subtypes. Then we have neuroendocrine tumors, under which we have small cell carcinoma, large cell neuroendocrine carcinoma, and carcinoid tumors. The others include large cell carcinoma, adenosquamous carcinoma, sarcomatoid carcinomas, and their variants. Then a small group of tumors which resemble the salivary type tumors. Whereas the clinical classification is different from the histological classification. This clinical classification mainly based on the therapy and prognosis, which is they have broadly classified them as small cell and non-small cell carcinoma. Small cell being 15%, whereas non-small cell carcinoma is around 85%. Under non-small cell carcinoma, we have adenocarcinoma constituting 55%, whereas squamous cell carcinoma 34%, and large cell carcinoma and others is only 11%. So now move on to the genomic alterations in non-small cell carcinoma. As in the last 3 decades, there is a lot of advances in the molecular pathology, which led to identify different types of mutations that are seen in lung carcinoma. And these mutations are extensively studied in non-small cell lung carcinoma. So these mutations are classified into 3 groups. They are mutations, gene rearrangements, and amplifications. The mutations are, it might affect the EGFR, KRAS, HER2, BRAF, and MET. Gene arrangements are seen in ALK and ROS1 and RET, whereas amplifications are seen in FGFR1, MET, EGFR, and HER2. So now let us have a look at how these molecular genetics will lead to the lung cancer. Before that, let us have the different types of mutations seen in non-small cell lung carcinoma. In adenocarcinoma, majority of the mutations have been extensively studied, and the most common mutation is KRAS, which accounts for 30%, followed by EGFR 20%, or is 7%. So the identification of these mutations in lung adenocarcinomas has definitely a therapeutic role because these patients will be subjected for targeted therapy. Whereas in squamous cell carcinoma, these mutations, some of the mutations are also seen, like FGFR, which constitutes 22%, whereas PIK3 constitutes 12%, but their role in the therapeutic decision is still under research. Now, moving on to the pathogenesis. Before moving to the pathogenesis, let us understand the cell cycle regulation and survival. As we all know that the cell cycle is regulated by 3 main pathways or the factors. One is extracellular component, intracellular component, and the cell cycle regulators. So the extracellular component are nothing but these growth factor receptors which are present on the cell membrane. They bind to the intracellular tyrosine kinase through the transmembrane domain. This the intracellular tyrosine kinase, it undergoes autophosphorylation, and then it there is recruitment of the proteins which are necessary, which carry the signals from the growth receptors to the DNA, which are known as signal transducers. During this process, it activates various pathways like MAPK, PI3, RAC, and JAK pathways, which allows the cell to enter into the cell cycle with their proliferation. But once it enters into the cell cycle, this cell division, it is regulated by what is known as cell cycle regulators. We have the positive regulators and negative regulators. The positive regulators, usually they allow the cell to enter into the cell cycle and divide. These are examples are cyclin and cyclin dependent kinases. Whereas we have the negative cell cycle regulators like P53 gene and RP gene. So these genes, they halt the cell cycle. That's how the entire cell cycle is regulated by these three factors. If there is any mutation either in the extracellular component or the intracellular component or cell regulators, it will result in the tumorigenesis. Now, moving on to the what are the different pathways that undergo molecular pathways that results in lung cancer. One is abnormalities in the growth stimulatory signaling pathway. So this may be like the mutations in the membrane-bound RTKs like EGFR are transforming growth factor alpha, or if there is a mutation in the intracellular kinases and targets, like these are the transducing signals. So like KRAS, BRAF, PI3K, all fusion proteins, or there may be abnormalities in the cell regulators like the abnormalities in tumor suppressor genes like P53 pathway and RB gene. Then the less understood pathways are evasion of apoptosis and epigenetic pathway. Moving on to the abnormalities in growth stimulatory signaling pathway, the mutations are in the membrane-bound RTKs. So this results in the deregulated signal, or the cell will be in an effector state so that it cannot be shut off from cell division. So these RTKs activation in cancer may occur via there may be increased expression of these receptors on the malignant cell, or there may be enhanced ligand production, or there is a continuous activation of these genes within the malignant cells, which results in cell proliferation. Whereas the mutations in the intracellular kinases or targets, these are intracellular signaling pathways. So when there is a mutation, so there is a continuous transmission of these RTT signals into the nucleus via cascade of specific protein phosphorylation, so that the cell enters continuously into the cell cycle. So there is uncontrolled cell proliferation. Now, moving on to the specific to lung carcinoma, EGFR mutation is seen in non-small cell lung carcinomas. As we all know that EGFR is a prototypical member of receptor tyrosine kinases, and it belongs to the ERK family, that is ERK1. It regulates the cell proliferation in normal resting cell. Mutations are deregulated expression of this gene results in it acts as an oncogene. EGFR mutations are seen in approximately 20 to 30% of non-small cell carcinomas, and they are seen in adenocarcinomas, non-smokers, and in Asian populations, and also it can be detected in females. So 85% of the mutations, majority of the mutations are seen in exon deletions in exon 19 and single point mutations in exon 21. Whereas a small subset of patients do have the mutations in exon 20, which is usually resistant to the treatment with TK inhibitors, as well as the EGFR wild type, where the mutations are negative. These patients are also resistant to TKI therapy. So this EGFR mutation can be tested by RT-PCR or NGS. As a screening test, IHC can be used, but the IHC is not a recommended test for the patients who are willing to undergo TKI therapy. For such patients, the EGFR mutation has to be confirmed by either RT-PCR or NGS. So let us understand how this EGFR mutation will lead to cell proliferation. As I said, EGFR is present in the extracellular space. This is nothing but a growth factor which binds to the extracellular domain. Through transmembrane domain, it gets bind to the intracellular tyrosine kinase. This causes autophosphorylation of these tyrosine kinases, and this tyrosine kinases, once it autophosphorylated, it results in docking sites for the proteins like GRB2, SOS, and RAS and PIK3. Once these proteins are recruited, they activate the pathways like RAS and MAPK pathway, PI3K and AKT pathway, and TK directly it may activate the STAT signaling pathway. All these pathways they causes gene transcription and cell cycle progression, resulting in continuous proliferation, invasion, angiogenesis, metastasis, and also they escape apoptosis, so resulting in lung cancer. This is an example. This is the HND section where the normal bronchial epithelium, here the tumor cells, adenocarcinoma, and metastatic to the lymph node. This is mutation sequencing where there is a mutation is seen, the blue arrow, and this is by fish where the red dots they indicate the high copy number of EGFR mutation in patients both in the primary as well as in metastatic tumor. So now moving on to the next alteration, that is ALK pathway. So ALK protein is a member of tyrosine kinase superfamily that is present in the intracellular component, and it is a transmembrane tyrosine kinase receptor. So this, whenever there is a mutation, it results in the formation of ALK fusion protein. This ALK fusion protein is formed by the inversion of chromosome number 2, and it binds with EML4. So this ALK fusion protein acts as an oncoprotein, and then it activates the RAS pathway, resulting in tumor formation. So the tumors carrying ALK rearrangements are usually, they are negative for EGFR and KRAS mutations. And these are found in young, non-smokers and females, and majority of the patients, they present with advanced stage disease. It occurs in approximately 4 to 7% of non-small cell lung carcinoma. It is found in adenocarcinoma, adenosquamous, and rarely in squamous cell carcinoma. This ALK mutation can be tested by IHC, FISH, or NGS. And the treatment for this is first generation ALK inhibitor. Crizotinib can be used in patients with ALK mutations. So this is an example where this is the different, like adenocarcinoma, moderately differentiated. These are the poorly differentiated adenocarcinomas. The IHC shows strong membrane positivity, whereas the FISH shows high copy number, and this is the gene sequencing shows mutations at exon 20, EML4, that is the fusion protein at exon 6. Now moving on to the KRAS pathway. KRAS, it is a member of RAS family, which is a proto-oncogene. It encodes for G protein, and it regulates cell proliferation. So first, KRAS, usually when it is present in the intracellular component, it is in inactive form because it is bind to GDP. Whereas external stimuli like growth factor receptors, when they bind, so this GDP through GEFs, it converts the GDP to GTP. So this GTP, it activates the KRAS. So the activated KRAS, when there is a mutation, it activates the pathways like RAF, TRT, and PI3 and AKT pathway, resulting in cell proliferation, survival, and metastasis. So these KRAS mutations are seen, most common mutations which are seen in non-small cell lung carcinoma, particularly in adenocarcinomas, and they constitute about 20 to 40%. Its prevalence is higher in Western males and smokers when compared to the Asians and non-smokers. And the most common mutations are seen in codons 12, 13, and 16. KRAS mutations are usually associated poor prognosis because there are no specifically targeted drug that is available for KRAS mutations, and it can be tested by PCR method. This is an example, adenocarcinoma of lung with the lipidic pattern. Here is the mutation at the thymic region. Here, this is the FISH technique, which shows these red dots. They show high copy number of KRAS mutation in malignant cells. So now moving on to the less common mutations that are seen in non-small cell lung carcinomas are MET exon 14. MET is a proto-oncogene that encodes a transmembrane tyrosine kinase receptor. It takes part in several carcinogenic processes such as cell proliferation. This amplification seen in 3% of non-small cell lung carcinoma, common in females and non-smokers, and also in the older individuals. It is seen in adenocarcinoma or adenocarcinoma with pleomorphic or sarcomatoid histology. High MET protein expression is also shown to have a poor prognosis. This can be tested by PCR or NGS. Now, ROS1 fusion. This is a proto-oncogene located on chromosome number 6, which encodes the transmembrane tyrosine kinase receptors of insulin receptor family. This protein domain is its mechanism of action is similar to that of ALK protein. ROS1 translocations are observed in 1 to 2% of adenocarcinomas, common in younger population and non-smokers. And there are various types of fusion proteins that can be seen in lung adenocarcinomas, but the most common fusion is CD74 ROS1 fusion. This can be tested by FISH, NGS, and PCR, but IHC is not recommended as in case of EGFR. So all non-squamous, non-small cell lung carcinomas has to be tested for ROS mutations. This is an example. This is adenocarcinoma of the lung with pleomorphic histology, and these red dots, they indicate the high copy number of ROS fusion protein in malignant cells. Now moving on to the next pathway, that is the alteration in the cell cycle regulators. So this is named under abnormalities in tumor suppressor gene pathway. So either it may be P53 or the RB gene mutation. So P53 gene, as all of us know, it is a tumor suppressor gene which is called as a cell gatekeeper. So its main mechanism of action in the normal cell is that when the cell undergoes damage, so P53, it arrests the cell not to enter into the cell cycle till the DNA is getting repaired. If the DNA or the cell damage is not repaired, so it allows the cell to enter into the apoptosis, so that there is no proliferation. It straight away it inhibits the damaged cell to undergo proliferation. Whereas whenever there is a mutation of P53, this inhibitory action on the cell proliferation is removed, so that the damaged cell with the damaged DNA, it undergoes proliferation resulting in tumorigenesis. So this mutation, P53 mutations, are seen in 90% of small cell carcinomas, and it is seen in about 65% in non-small cell carcinoma. The patients with the P53 mutations, usually they have poor prognosis, and then they are usually resistant to the protein treatment. Now moving on to BRAF mutation. BRAF encodes a serine threonine protein kinase that is downstream effector of protein KRAS. It activates the MAPK signal transduction pathway and regulates cell proliferation and survival. It is more common in present and former smokers and also in females. It is primarily seen in adenocarcinomas, whereas other histologies are rarely described. And it is seen in 2 to 4% of small cell carcinomas. The common mutation is, as we see in brain, it is also BRAF V600E, and it can be tested by PCR. So RET mutation, it is a proto-oncogene. This encodes a receptor against tyrosine kinase, and its mutation leads to oncogenesis. Most common in adenocarcinomas and adenosquamous carcinoma. It is seen in non-smokers, former smokers, poorly differentiated tumors, and it causes early nodal metastasis. And it is seen in only a very small percentage of non-small cell carcinoma, which is about 1.4%. This can be tested by FISH, RT-PCR, or NGS. So now the other pathways like evasion of apoptosis. So it is a major mechanism of tumor growth, but it is still under research. As we know that BCL2 is an anti-apoptotic, whereas BAX is proto-apoptotic. So overexpression of this BCL2, it leads to evasion of apoptosis and thus causes carcinogenesis. And this is seen in small cell carcinoma and large cell neuroendocrine carcinoma, and it is very rarely seen in non-small cell lung carcinoma. Then epigenetic pathway, epigenetic modifications, they refer to the number of molecular mechanisms that regulate the gene expression, but they don't alter the structural change. There is no alteration in the DNA sequence. So the examples for this are DNA methylation, then histones and microRNAs, and their role in the pathogenesis of lung cancer is widely under research. Now moving on to the types of specimens what we receive for lung carcinoma are, it may be a tissue sample by small biopsies like CT guided biopsies, or it may be transbronchial biopsy or endobronchial biopsy, or the core biopsy from the mediastinal lymph node, or it may be a resection sample. And the cytology, we get FNAB samples, cDNA, and effusion samples. So both tissue and cytology samples are the suitable specimen for molecular genetics. Whereas the blood, we can detect the cell-free DNA or circulating tumor cells or exosomes, but this is routinely not used for the molecular analysis. Moving on to the morphology and IHC in non-small cell lung carcinoma. If the morphological characteristics are distinctive, then the sample may be directly sent to the biomarker analysis. And the use of IHC is recommended for the cases where the morphological diagnosis is unclear, where we are not very sure whether we are dealing with adenocarcinoma, large cell carcinoma, or squamous cell carcinoma. A minimum number of antibodies to be ordered to arrive at a consensus or the confirmatory diagnosis. a minimum section should be taken because we have to save the sample for biomarker analysis. And the terminology non-small cell lung carcinoma NOS is reserved only for the small biopsies and for cytology samples. So this is the adenocarcinoma of the lung with the lipidic pattern, which is previously called as bronchiolo-alveolar carcinoma, so that there is a strong expression of TTF1 in the tumor cells in the nucleus. This is another biopsy of a patient, endobronchial biopsy. This is the bronchiolar mucosa, and the wall is infiltrated by tumor cells, that is squamous cells. And here, these tumor cells are positive for P40. So a few words about immunohistochemistry in lung cancer. So for the diagnosis of adenocarcinoma, we recommend TTF1 and Naxin A, whereas for squamous cell carcinoma, it is P40 and CK5/6, whereas small cell or large cell neuroendocrine carcinomas, we use CD56, synaptome, and chromogranin. So a few words about the non-small cell lung carcinoma NOS. As I said previously, this NOS is reserved, this diagnosis is reserved only for the small biopsies and the cytology samples on routine HND and MGG and PAP, where we are not very clear of adenocarcinoma and squamous cell carcinoma. So in small biopsies, this constitutes about 30 to 50%. So with the aid of IHC, this NOS component can be brought down to less than 5%. So the non-small cell carcinoma with the P40 positivity, we call them as squamous. If it is TTF1 positive, it will be labeled as adenocarcinoma. If CD56 is positive, it is labeled as large cell neuroendocrine carcinoma. The tumors which are negative for all these samples with a non-small cell histology will be labeled as non-small NOS, that is not otherwise specified. So the recognition of this condition is important because these patients are also will be subjected for genetic or molecular genetics. Moving on to the role of pathologist in the diagnosis of lung carcinoma. So the pathologist play a key role right from sample processing to the selection of sample and the interpretation of the test. So the ideal fixation used is 10% neutral buffered formalin, and the fixation time is between 6 to 48 hours. And the most important thing is if the sample is small, the section for biomarker testing to be cut immediately before analysis. And the other important point is IHC test has to be chosen when the morphological characteristics are not favorable for a definitive histological type. The cytology samples can also be used to detect EGFR and all rearrangements. The pathologist should evaluate the availability of tumor material before sending the sample for biomarker analysis, and both in the tissue sample as well as in the cytology sample. And also they have to analyze the percentage of tumor cells and also the quality of tumor cells. Then pathology should be involved in sample preparation for DNA extraction and enrichment of samples to maximize the tumor cells content before DNA extraction. So now coming to the molecular testing, a tool for targeted therapy. As we all know that molecular diagnostics guided targeted therapies have become a standard treatment option for patients with non-small cell lung carcinoma. It is recommended for all adenocarcinomas, but not for squamous cell carcinoma. The first line of mutations are EGFR, ALK, and ROS is a must for all adenocarcinomas, whereas MET1, HER2, BRAF, and RET mutations are generally not indicated as a standalone assay. These may be tested if the patient is negative for EGFR, ALK, ROS1, or if the patient was previously positive for these mutations. Now he has progressed on therapy. Such individuals we might recommend for these mutations. Now, summary of recommendations for a molecular testing of lung cancer. So histological types which are indicated for molecular testing are adenocarcinoma, large cell carcinoma, non-small cell carcinoma NOS, and the patients with mixed histology. So the clinical indication includes if the patient is young, he is a non-smoker, and small biopsy where the adenocarcinoma component cannot be completely ruled out. And what are the tests for molecular testing? It can be IHC except for EGFR and ROS1, or FISH, PCR, and NGS, new generation sequencing. What are the types of samples suitable for molecular testing? Or the biopsy sample, it may be cytology sample, the sample from either the primary or metastatic lesions are equally suitable for molecular testing. Then if the patient has multiple synchronous lung primary, then each tumor has to be separately tested for molecular testing. Then what is the specimen requirement? The most important is that the presence of tumor cells in the small biopsies, which has to be certified by the pathologist. And if it is more than 50% of tumor cells are present, it can be sent for direct sequencing. If the percentage of tumor cells are less, they can be subjected for a more IH sensitive methods. And 50 to for FISH technique, at least 50 to 100 accessible tumor cells should be present. Now, a few words about PD-L1 and immunotherapy in non-small cell lung carcinoma. So PD-L1 is an immune checkpoint protein that regulates the immune response to prevent excessive or chronic autoimmune inflammation. It is expressed, PD-L1 is expressed both on immune cells as well as on tumor cells. It inhibits the T cell activation and induces T cell exhaustion. Selective blockade of PD-L1 is used in the treatment of non-small cell carcinoma patients to reactivate the T cell mediated immunes, that is T cell mediated tumor killing. So now what are the methods that can be used to detect PD-L1? It is IHC by using the on-paraffin blocks. The minimum of 100 viable tumor cells must be present for evaluation. It stains both immune cells and tumor cells, whereas in case of non-small cell carcinomas, they take the expression on the tumor cells, which is called as tumor proportion score, which can be detected by number of tumor cells which are expressed to PD-L1 divided by the total number of cells into 100. If TPS score, if it is less than 1%, there is no PD-L1 expression. It is intermediate expression between 1 to 49%, where is PD-L1 expression. Whereas if the TPS is more than 50%, it is high PD-L1 expression. So the patients with high PD-L1 expression can be subjected for immunotherapy, provided they should not harbor the EGFR or genomic aberrations, or they have not received any systemic chemotherapy before institution of immunotherapy. This is an example where the PD-L1 testing by immunohistochemistry method. Here the tumor cells as well as the lymphocytes, that is immune cells, are negative. There is no staining. This is a weak staining on tumor cells. This is moderate staining. This is intense staining on the tumor cell membrane. So this is a squamous cell carcinoma where the tumor cells are negative for PD-L1. It is positive for immune cells. This is a non-squamous and non-small cell lung carcinoma where the tumor cells were positive for the PD-L1 expression, whereas the immune cells are negative. So this, let us have a look at algorithm for diagnosis of non-small cell lung carcinoma. Before analyzing the sample, we need to have the clinical information. So the most important clinical information is that the sample site. So which site the sample is taken, whether it is from the primary tumor or from the metastatic tumor, and also relevant medical history, whether the patient has received any previous chemotherapy or not. Then the most important history is smoking history. So the sample, when it is processed on HND, if the morphology is very clear, if it is squamous, it falls into the category of squamous cell carcinoma, that sample should not be tested for molecular abnormalities, except in clinical indications like if the patient is if he is a non-smoker, or if the tissue sample is small where the ADC component is not completely excluded. If the morphology is clear, that is adenocarcinoma, then as a first line of genetic mutation, we have to test for EGFR either by IHC and also as well as the alpha. If EGFR IHC is positive, then you confirm it by the FISH technique, PCR or NGS. If EGFR is mutated, then the patient might receive the TKI inhibitors. Whereas if the EGFR wild type, where the EGFR mutation is negative and the ALK is positive on IHC, it has to be confirmed with FISH. If the FISH ALK is positive, then again they can receive TKI. If the FISH ALK is negative, then you consider other mutations like MET, HER2, BRAF, etc. If both EGFR and ALK both are negative, then you request for FISH ROS mutation. So if fish ROS is negative, again they have to be tested for MET HER2 BRAF. If the fish is positive, the patient might receive TKI. So if the morphology is not obvious on HND, then we go ahead and do IHC. So if the TTF1 is positive and P40 is negative, then it is adenocarcinoma, so that it should go through the same pathway. So this patient has to be tested for all the three mutations, that is EGFR, ALK, ROS. Whereas if TTF1 and P40 is both are negative, such cases which are labeled as non-small cell lung carcinoma NOS also should follow the same pathway similar to adenocarcinomas. If the P40 is positive, then it favors squamous cell carcinoma, so it doesn't require molecular testing. So when you are handling the sample of metastatic non-small cell carcinoma, so what is the preferred method of doing the molecular analysis? If the histology is non-squamous, or if it is a squamous histology who is a non-smoker or a light smoker, or if the patient has both mixed adeno and squamous histology, the mutation analysis is a must, and the preferred method is by next generation sequencing, and the minimum genes to be analyzed are EGFR, ALK, ROS1 and BRAF. So if the driver mutation is present, then it can go for targeted therapy. If there are no driver mutations, then no targetable mutations, then the patient can be subjected for PD-L1 testing and for immunotherapy. Even squamous histology can go for the PD-L1 testing. So a few words about liquid biopsy in non-small cell lung cancer. So liquid biopsy or non-invasive blood test, which refers to analysis of any tumor-derived material which is circulating in the blood or the body fluids. So liquid biopsy is relevant in lung cancer as the tumor is often difficult to reach and may have an invasive and potentially harmful procedure. It detects circulating tumor cells, cell-free circulating tumor DNA, and then also microRNAs and exosomes that are shed into blood or into the body fluid from the primary or metastatic lung carcinoma. So indication for lung biopsy is to detect minimal residual disease to guide the adjuvant therapy, or early detection of relapse before the clinical manifestation, initiation of systemic treatment and monitoring of response like targeted or immune therapy to detect resistance genotyping, and also it can be used as a screening technique. To sum up the entire thing, so the lung cancer is the leading cause of cancer-related deaths with poor prognosis. Advancement in molecular pathology make it possible to detect specific genomic alterations, particularly in non-small cell lung carcinomas, and that too in adenocarcinomas. This has transformed the management of patients with conventional chemotherapy to personalized targeted therapies. All patients with adenocarcinoma histology has to be tested for EGFR, ALK and ROS1 mutation, which helps them for therapeutic decision. Liquid biopsy in future days may play a significant role as a prognostic, predictive and diagnostic tool. So I think with this, I am ending up my session, and thank you everybody. If there are any questions, I'm ready to take them.
If anyone has any questions, they can raise their hand. There are a few questions in the chat box, ma'am. One is, how do we deal with biopsies if the tumor load is between 5 to 10%?
So if the tumor load is 5 to 10%, I think this sample should not be sent for the molecular genetics, because they minimum require at least 50 viable cells. So in such cases, we have to request for resampling, or if the patient is already been diagnosed, then we can go for liquid biopsy.
Ma'am, is TTF1 preferable to napsin in adenocarcinomas?
Yeah, TTF1 usually, but what in my experience, like I will put TTF1 as a first line of IHC marker. But some of the squamous, sometimes even the squamous cell carcinomas do express TTF1. In such cases, when there is a dual expression of both TTFN and P40, so I prefer the Napsin A so that if the Napsin A comes positive, it is more specific to label it as adenocarcinoma.
Ma'am, one more question is how much percentage is 50 viable cells?
I think, can you please repeat the question?
Ma'am, how much percentage is 50 viable cells?
How much percentage? It is not that. If it is a small sample, at least that is morphologically intact, 50 tumor cells should be present. Whether it may be a biopsy sample or a cytology sample, 50 tumor cell clumps should be present. Minimum number, it is not the percentage number, at least 50, that the entire sample should contain at least 50 tumor cells.
Okay, thank you. No more questions, ma'am.
Thank you.
Thank you, ma'am, for your enlightening and interesting talk on molecular lung pathology and detailed explanation on pathogenesis, importance of mutations and molecular genetics and immunotherapy for targeted therapies. We are grateful for the time and effort you took to share your thoughts and experience with us, ma'am. Thank you, ma'am.
Thank you. Thank you so much.
We will now break for lunch between 12 to 2 p.m. and join back at 2 p.m. For the session on the liquid biopsy in cancer biopsy by Dr. Biba Chaudhary. Thank you.
Leave, ma'am.
are making sure that they get benefit of hormone therapy, and by not giving
Good afternoon all. I, Dr. Soumya, welcome you all for today's post-lunch session. Next session is by Dr. Biba Chaudhary, Faculty Scientist, Institute of Bioinformatics and Applied Biotechnology, Bengaluru. Now I request Dr. Manjula K, Professor of Pathology, to introduce the speaker.
So good afternoon all. It's my pleasure to introduce Dr. Biba Chaudhary. So Madam is working as faculty scientist at Institute of Bioinformatics and Applied Biotechnology. Our current research topics are cancer therapeutics, genomics, transcriptomics, and metagenomics, non-coding RNA in cancer, chromosomal translocation in cancer, genomics of rare diseases. Dr. Biba Chaudhary has 16 years of experience in the field of developmental biology and molecular biology. She received her PhD degree from Center of Advanced Studies in Zoology, BHU, Varanasi, in the area of cytogenetics and molecular genetics. She did a postdoctoral work at Institute of Genetic Medicine, USC, Los Angeles. She focused at understanding the role of neural crest stem cells in cardiovascular malformation. She is working on mechanisms involved in specification and differentiation of cardiomyocytes using embryonic stem cells. She developed a novel protocol for differentiation of cardiomyocytes from human embryonic stem cells. And apart from that, she also has experience in culturing mesenchymal stem cells from various sources. She carried out her work on molecular mechanisms of translocations in cancer and drug screening in cell lines as well as animal models of cancer. Her lab at IBIB focuses on the role of non-coding RNA in disease and drug-induced changes in a microRNA. She works in collaboration with Dr. Subhashini Srinivasan on genomics and transcriptomics of prostate cancer, breast cancer, ovarian cancer. She also is involved in genetics of rare diseases using NGS. Dr. Chaudhary has more than 40 publications in national and international journals. Over to you, ma'am.
Thank you all for joining back after the lunch, and thanks for the nice introduction and the opportunity to talk at this forum. I must say I really enjoyed looking at all the histopathological images in the morning, and I think we need to get better at that in order to do further or contribute to cancer field in any sense. That is important, that the histology is undoubtedly needed for the entire area of cancer, and genomics only adds to make it or give an additional angle to it. So with that, I'll start with the presentation, and that's about how to use, what are the alternate methods of finding out cancer at much earlier stages, and that's that about. So today's talk is divided into understanding this. So what you have here is, let me move this up. So you have topics which cover under this topic. We'll cover this 4 subtopics. And the first one is liquid biopsy itself. I'll just tell you what does that mean and what progress has been made in the field of cancer biology. Of the most important and where we began with was understanding of circulating tumor cells, but I'm more going to be on technical aspects of it and saying how is it isolated, what is required. So more of technicalities will be there. So please, you can interrupt me in between if you want. Cell-free DNA from blood and the tumor-educated platelets and exosomes. How are we using this in terms of identifying cancer and why do we need this? So you all know diagnostics is a big field by itself, and cancer diagnosis is the largest market right now. So what you are seeing is this window here. Just a second. So you have listened to the morning topic of histopathology. Of course, tissue biopsy makes up for a lot of cancer diagnosis, imaging, and of course the newly coming one is liquid biopsy. And why is that needed? Where is the need for such a change in methods of diagnosis is a matter of real debate, but maybe today's presentation will help you a little bit get into it and say, yeah, maybe this is a better method, along with tissue biopsy wherever needed. Wherever we can give up tissue biopsy and take liquid, we should be able to do that. So liquid biopsy, by the name itself, you know, is more to do with a non-invasive blood test, which can detect circulating tumor cells and fragments of tumor DNA that are shed into blood from the primary tumor and from metastatic sites. So when the tumor is growing, it is also dying. And when it dies, it sheds the DNA. Similarly, when the tumor is growing, it also, some of the cells escape the tumor and land up in blood. Can we just take that up and make it a diagnostic is what has led or made this field develop. So what you're seeing here is and the difference between the blood and the tissue biopsy would be this, that blood can be a real-time liquid biopsy, which means you can collect blood at different times of cancer from cancer diagnosis and for its prognosis at different times. And then you can look at markers in the blood which will help. And these are the markers which we are going to be focusing on. And what you're seeing is what I said just before, the CTCs, the cfDNAs, or the circulating tumor DNA, exosomes, and the platelet, the tumor-associated or tumor-loaded platelets, tumor-memoried platelets. I'll tell you about each one of them, and that begins with this understanding. What are we going to do with the CTCs? Okay, I found CTCs. Which are circulating, which left the tumor and has moved out. It is in the blood, I can take it out, but what am I going to study? And this is where all these come in, the whole idea of CTCs or the ctDNA or microRNA as biomarker. I'll not go into details of this, but what you're seeing is a clinical application of the liquid biopsy. So it has function in both the early detection as well as the response to therapy. So you can see there is a range in which the liquid biopsy can find its application, and you are seeing diagnosis or prognosis, understanding minimal residual disease, depending on what mutations you got, you could go ahead with therapy. If therapy is really working or not. So response to therapy is something that we can again do. So at each point, you know that we are collecting blood in order to do the assay. Um, One of the major problems in the cancer is the resistance to drug, and we would really want to understand it way before the cells which have got mutations and grow in numbers such that the drug will not be functional. So can we do that? And that's where this has come in. How do we do it? You all know that as a biomarker, you have been assaying protein, or you assay, say, some gene panels where you're assaying RNA, or you also check for certain SNPs or SNVs in the DNA. All of these can be achieved even if we take the liquid biopsy, because in liquid you have all of these present: the CTCs, the microRNA, the exosomes, the platelets, and as well as the tumor DNA. Just 1 second, please. Okay. Sorry for the interruption. There was some emergency here which needed to be fulfilled. But what I was talking about was what do we see in these and how do we measure it? So we measure chromosomal aberrations. We also have an access to understand methylation patterns, point mutations, translocations, RNA expression, and protein expression in these cells. And therefore, whatever you did with the tissue can be done with the cells or the DNA collected from the blood. So it's not really different, but why is it difficult, and how much information can we get? Do we get the similar kind of information, or it's information which will complement the information from histopathological studies? So these are the challenges that the clinic faces all the time. One of the major challenge is to really shorten the time to diagnosis and the invasiveness of the entire procedure. So maybe non-invasive methods would be ideal, and this is sort of non-invasive. We can also have limited but robust evidence that is based on molecularly predicted primary. So one of other problems in the cancer is to find out the primary site from where metastasis has happened. So most of the time we see metastatic site and we start treating, but the primary site information is important for the treatment, and that this can help in finding out tissue of origin, and that's something that has become a new trend. We also know that there is 10 to 20% failure rate for molecularly profiling tumor tissue, and that is something that can be worked on. Also, the question is, how representative is a single small biopsy of one metastatic lesion? So you got biopsy and you have tested it. Does it really tell all about the tumor or the cancer itself? Therefore, an alternative, as in liquid biopsies. So to just give you an idea that, these are recent papers which have happened in last 5-6 years, and a lot of progress has been made in the field of liquid biopsy. Now, one of the major things that people want to know is the tissue of origin, and that has become a trademark in terms of liquid biopsy itself. So how do we do it? I'll get back into that. So we asked this question, where could liquid biopsies fit? What can we do with this? And this is what you can do. It could be used in diagnosis, where you determine primary site and you have a quicker diagnosis to direct investigations. You have management decisions to make, so prognostic information, molecular subtype to stratify treatment can also be done. And not the least, but to understand the resistance. So these are the uses where it can fit in. Liquid biopsies can really provide an answer to some of these questions. Based on the tissue of origin and the biomarker status, we can then treat the tumor type. We can decide on targeted therapy, immunotherapy, and so on and so forth. So last but not the least is understand the biology, and that's critical for researchers like us, because we would like to find out what makes CTCs different from the other tumor cells, and how are we going to identify, how are we going to isolate it, how can we ease the process of using it as diagnosis. So you all know this, and this is a tedious task for all of us. So you know that the circulating tumor cells are going to be very, very rare, that 1 ml of a blood is really a small fraction in a teaspoon. So you are looking at that. That carry is actually loads of RBCs, WBCs, and in that you have to find 1 to 15 circulating tumor cells. It's like needle in a haystack, and that's the big job that one has to identify and then design a method in order to get this. So what kind of a progress has been made in this field? So this is just to give you an idea how does it look like. It seriously is a tedious task. We understand this, and we are going to look at it. So one of the ways by which we identify CTCs is by the size. So we are looking at the size of all the white blood cells and the erythrocyte, and you see that the CTCs actually would fit in somewhere in the sizes where monocyte, eosinophil, and basophil are also coming along with neutrophil. And there's a concern. But you also see that there is a different range altogether to it, which is 12 to 25, unlike neutrophil, basophil, eosinophil, where you see it as 12 to 15, except for monocytes. So there is a chance that we actually land up picking up monocytes along with CTCs. And therefore, we need to better find out ways to segregate them. So there are technical issues that I'm talking about in CTC. So the other problem is, although we know a lot now about CTCs, but not all CTCs have what we use as a common marker, the EpCAM, the epithelial cellular adhesion molecule, which is present on most CTCs, not all CTCs. And this is a great marker of epithelial to mesenchymal transition. And this is a step where the movement of the cell happens. So now that we are thinking from a primary site, a cell has moved via epithelial mesenchymal transition. this cell actually has acquired certain markers, and these markers are what we are using in order to take them out. But again, reiterating, all CTCs do not express EpCAM. Therefore, size is one of the ways which is still a way to find CTCs or isolate CTCs. So just showing you the various ways by which CTC separation is done. One is by size, and as I mentioned, it can be sometimes a little confusing. And if there are clumps, there are problems that we will see. Many microfluidic devices have come into existence now with the whole idea that we should be able to segregate CTCs that way. Or we could segregate by simply density gradient centrifugation and then go ahead with the immunomagnetic separation using antibodies. So, and then subject to multiple different methods. Uh, you are also seeing that the circulating tumor cells um, has brought in a new technology altogether, and these are called as nanochips and microfluidics. Now, how does this work? So they work on a pretty simple concept, and the concept is that these nanomaterials would be tagged with antibodies, very specific to the CTCs, for example, EpCAM, and it will also be tagged with something else. So I'll come back to that. So negative selection and positive selection is possible for CTCs, and that's how we would pick up CTCs and not monocytes. So looking at this, that there is a need to just segregate CTCs, and therefore came the new technology using magnetic nanowires. And these magnetic nanowires help to just segregate out greater than 90% of the CTCs. So I'll just show you what we do. So in order to just get CTCs isolated, we have a magnetic surface to which we have attached the EpCAM antigen or the EpCAM antibody. Similarly, for negative enrichment, we have attached CD45 antigen and antibody. Now, when you pass the mononuclear fraction through this, now you should know the CTCs which have got EpCAM expression would come and bind to the EpCAM antibody, and that's how that will be segregated. The other cells expressing CD45 would go and bind to the other surface. Now you can actually just flush out the positive enrichment ones one time and then put it back onto negative enrichment and then take out all that were positive because they'll not bind at all. So what you're seeing is a design of the magnetic nanowires. And this design, you are able to see that there is antibodies. There are antibodies which are attached to it. So we can attach like 5 antibodies is what is shown over here. But you could do 1 antibody, you can do 5 antibodies. It really increases the cost a little bit, but it makes it better to take out just the CTCs. Now you have RBCs, WBCs, and CTCs. The only thing that will bind is CTCs and not the others. Therefore, you would be able to segregate CTCs. Now you can work with the CTCs in many, many ways. People have tried finding out sheer number of CTCs and correlating that with the stage at which the cancer might be. Before even they have to make such a statement, they need to go ahead and show that the CTCs are true CTCs. And that is done by doing IF or immunofluorescence, where they have used EpCAM antibody, CD44 antibody, and you can see you can really recover greater than 90% of the CTCs if you follow at least 5 antibody method, where positive and negative selection are both included. If we use just 1 antibody or 2 antibodies, we do land up with more impurity in it, and we might be wrong at times in diagnosis. So it's sort of little expensive, but we can definitely see them even though the numbers are really small. So what you're seeing here is how CTCs look like from cancer patients, and here is immunohistochemistry on the right-hand side, and scanning electron micrograph pictures of that. Down you see the EpCAM stain and bimentin stain cells, which indicate that they are CTCs. Now, they do morphologically look different than the normal cells, but they will not stain for CD45. So this is how it looks. If I take 1 ml of blood, I'm expecting really low number of CTCs, and we have to work with this. Is it really feasible? Is it doable? Is it really worth taking the risk, or shall we only do the histopathology? And where is the need to just do a liquid biopsy if we were able to do histopathology? This can be debated, and the question always have been, the urge for all of us has been to have a non-invasive method and an early detection method for cancer. So what you're seeing here is one of the examples where number of CTCs was counted per 3 ml of blood in this case. And what you are seeing is very rarely in normal individual you find CTC. There is one case here that you are seeing where arrow is pointing towards that. But if you look at the cases in cancer, there are a few arrows that you can see where you did not find any CTC, but most of them showed CTCs, and you can count the number of CTCs. So you are seeing maximum number of CTC being somewhere 9 CTCs, and the minimum number being 1 CTC2. Now, what does this tell us? Is this a foolproof method to do it, or it's a questionable method in terms of counting CTCs, because one normal individual did show that. Now, that's where more examples will help, where people have done this with lung cancer. And in lung cancer, you will all appreciate much better than what you saw in the breast cancer. Every individual has it. And normals, although very few normals are here, so none of the normals actually show it, whereas at least 4 or 3 CTCs are seen, and the number of CTCs are much larger in lung cancer than was in the breast cancer. So what we realized also was that the CTCs were quite cancer specific too, independent of their metastatic nature. So it could be telling us something more about how the lung cancer cells and why the lung cancer cells would move more into the blood than the breast cancer cells. And that is understandable. But if you look at prostate, then you will find that the CTCs over here are also present in quite good number. Normal, again, I think it's the same normal, so it doesn't show you anything, but it shows in prostate cancer. Now, so what we get to know from this is 2 things. One, definitely there is a way out to use CTCs and find out cancer versus normal, that the CTCs vary between cancers. Some cancers might have large number of CTCs and some will have small number of CTCs. And therefore, there is a work going on to just figure out all cancers, what is the level of CTC, and that will bring clarity. Now, this is one example which I'm going to show you how the CTCs have helped. You are seeing in a lung cancer patient the CTC before and after surgery. So before surgery, they have counted it 6 CTCs per 3 ml of blood, or rather 2 CTCs per ml of blood. But this study did not explore 1 ml. They have taken minimum volume as 3 ml. So you have EpCAM staining, you have bimentin, I have shown you this, and the CD45. So you do see a reduction in the staining also of these markers. Not only the number, the reduction. You can see that before surgery there were 21 CTCs in clusters seen. After surgery there are 9 CTCs per 3 ml. So this kind of work has gone on to just prove the fact that the CTCs can be used for the purposes of understanding whether the disease is really under control or it's not reacting at all to the treatment. This is a comprehensive analysis by Cell Search. Cell Search is a company which is actually producing all the antibodies for CTC research, and they have compiled this data, and it's a beautiful data that is there, where you can see that in normal, so you are seeing healthy controls, you are seeing benign disease, you are seeing baseline 3 to 5 weeks in the breast cancer patients, then you are seeing in the colorectal as well as in the prostate. And what you will all appreciate is this, that in healthy controls, you might find one CTC 3% of the time, and you never find more than one CTC. You don't see 2, 3, 4, 5. This doesn't happen. In benign disease, it increases to 7%, and in the breast cancer, if you're all looking at it, you can see it increases by much larger amount. So number of CTCs that we see is quite large in case of cancer. Therefore, it's a very distinct feature. It's not from normal or healthy controls that we'll see nothing. We'll see something. Even from benign disease, we can see something. But definitely, it's a contrasting difference between cancers and the normal. And we are talking about metastatic disease, though. We need to also see different stages at which it can vary. So there are two groups here, and different groups are representing to you the different numbers slightly, which varies a little bit. So at 3 weeks versus at 5 weeks, you will also see certain differences, and that is evident it might be. So unfortunately, we are talking metastatic disease, and it was easier for them to collate this data. I would have really loved to see more of this from the first half of, or when the cancer begins. So there's a stage between benign disease and the metastasis, and that is where people are working on to find out if you can really classify them. So there's a lot of progress being made in terms of how CTCs can be used. Using CTCs, the next job was to find out if we could do also analysis of very specific variants that are known. So one of the methods which has come along with CTCs is a droplet digital PCR. So what happens in this is pretty simple. It doesn't require many cells. One cell in the entire volume of the blood is sufficient to be diagnosed. So the sensitivity is really, really high. The reason being pretty simple. So if you have, say, you have created droplets, and every drop has one single cell, that single cell will get amplification done within that drop. Therefore, I would be able to actually see that drop as a single cell, and we can visualize if the mutation is there or not. And that's the picture on the right hand side, which shows you that a positive mutant, how would it look like, where you see single dots, as in blue dots up there, representing single cells with the mutation. So you can count the cells, you can count the number of cells which showed mutation. So the sensitivity has been improved by additional techniques like droplet digital PCR. So isolate CTCs and then go ahead and also do a PCR on it, such that you can identify mutations within single cells. Today was about CTCs, one of the liquid biopsy initiators. When it all got initiated, it was all about that. We soon realized that isolating CTCs was not going to be super easy. It's really difficult. It takes a lot of money and time. It has its own benefits, as in I can culture it, I can study it. Biology is a lot to learn from that. But for diagnosis, we require something more. We want to find out how quickly and with how little amount we would be able to make a big change. And that's where the concept of circulating tumor DNA came in, where we again understand this, that the circulating cell-free DNA comes from the cells which are dying by normal apoptotic cell death within the tumor area. And what we know about how the apoptosis happens is this, and you can see that graph. So when the cell is dying via the process of apoptosis, it actually has a certain amount of DNA attached to a particular nucleosome, because DNA is complex with protein inside the cell, and it stays in this form. So when the entire process of apoptosis happens, it actually can form mononucleosome, dinucleosome, and a trinucleosome. And the tumor-related cccFDNA, or the circulating cell-free DNA, levels increase at advanced stages. And the fragmented DNA would be seen in the plasma or in serum at around roughly 166 base pair average length. So we can find it as mononucleosome, di, and a trinucleosome, and that's what is shown over here. But mostly it's very, very small fragment that we are looking at. The only problem with the circulating cell-free DNA is when you take out blood from the individual, you will have to collect plasma and immediately store it, because the average half-life is less than 2 hours for the circulating cell-free DNA. And that's a big concern because this doesn't happen in the clinic as fast. So we need to, just like we collect blood and count cells immediately, we need to also collect plasma and store it right away so that we can get the smaller fragments. So what do we start with? How much of plasma is required? What do we understand about all of these? So you just saw that the smallest fragments, or 166 base pair DNA fragments, are what are coming from the tumor. And this is something that we want. We also want that the technique be sensitive enough to pick up very, very low frequency variants if we were to find out what are the mutations that are seen, where is the mutation, such that we can actually treat it. The amount of cccFDNA that we can get from 5 ml of plasma extraction is only 30 nanogram. Now that's more than enough, I must say, and that's not a big problem. So you do get short sized fragment, and that is distinguishing feature. So how can we extract it? How do we go about taking out cfDNAs from plasma? And what you're looking at is, again, magnetic nanowires, which are coated with PEI to just bind to the DNA. DNA is negatively charged, so anything that can help or has a positive charge will increase its binding. So you have got the PI conjugated magnetic nanowires, and what you're seeing is plasma, and you can also see on the right hand side PBS, and you see these particles all over the place. Now we can actually collect the DNA and do a proteinase K treatment and collect out the DNA from, separate it out from nanowires. And once we have separated it out, we can subject the DNA to the mutation analysis by simple PCR. Or we could sequence it. We could do next-gen sequencing with this and find all variants that are seen in a particular individual, And we might understand heterogeneity to the core because the DNA that is shared might have many different mutations. Just by assaying that, we might be able to categorize individuals into low level of mutagenicity versus very high level of mutagenicity, and that will tell us what to treat with. So to understand this and for us to understand how to make this process efficient, we have done an assay where we have taken nanowires and supplemented it with the DNA from outside. And that process is called as spiking in. So we add it to enhance the recovery of the DNA. And that is pretty simple concept. When something is pretty diluted, it will not form aggregates. So we actually add a little extra to create a maximum aggregate, and the efficiency of capture can be increased. And what you're seeing on the right-hand side is that the efficiency of the low-range DNA and the middle-range DNA can be enhanced by adding extra DNA from outside. So this is just to show you again that if you took out the DNA from healthy individuals and if you took it out from the cancer patients and the cancer patient has a mutation, we can actually find that mutation pretty easily with this kind of DNA. The question is the DNA fragments that we are picking up, are they having all the mutations? And that is yes, we will be able to get it, even though in very, very little amounts. So you got that the process itself is standardized. It's not as bad. The question is, can it come to clinic and can clinicians really take a call based on this? And that's where the entire process is in order to bring it to the clinics, just to have an idea. It would take some time, but it would be there wherever needed, and we must start experimenting. This is just to show you that if you are really interested in going on doing ctDNA, then there are nanowire networks that I just talked about, and a comparison with QIAGEN, which maybe all of you are pretty much aware with. And what you're seeing here is nanowires are doing pretty efficient job at taking out DNA. Therefore, the standardization of these techniques and understanding what to use is equally important to say whether the system or the technology works efficiently or not. This is one of the big trials that is on in UK, which is called Target ctDNA trial. And in this case, what they're trying to do is to understand multiple things. So you're looking at all solid tumors, the DNA taken in, ctDNA and germline controls are there because your blood controls are there with you. So you can do a next generation sequencing or of a 360 gene panel that you are interested, or 650 somatic mutations, and stratify it in a tumor board, which you are all more aware than me. This will allow for a determination of tissue of origin and the other important aspect, which is copy number variations that are seen in the genes. For example, all of you know that the MYC is amplified. And in all those cases, if we understand that, the treatment can be guided treatment. So tissue of origin is very important to find out or give a direction to the therapy. And of course, this all make up for a good understanding of other concepts which I have not dealt with, and it's mentioned here. One of the things, and nobody has asked me, so I better answer this question. Using ctDNA or CTCs, how do we know from which tissue has the cell come from? Although it has migrated from primary tissue, it has gone to some other metastatic site or secondary site, it has signatures of the primary. What are these signatures and how do we find out these signatures? I hope you have all studied this and you have some idea that DNA has 4 bases, G, A, T, and C, and that the C is methylated very, very tissue specifically. Therefore, when we do a methylation assay on the DNA from individuals, we would know by simply doing that whether it has migrated or moved from lung, breast, brain, prostate, kidney, wherever, because every tissue has a very specific methylation signature, and that's where all this comes in. So with this DNA, you can just do a methylation assay, and methylation specific primers are there. We just simply do PCR to find this out. And then here it is, the paper which I'm talking about regarding the target ctDNA trial, which is done at a massive scale to understand the utility of ctDNA to support patient selection for early phase clinical trials. So yeah, the work is on with the ctDNA for now in terms of bringing it to the clinic and making it available. What you're also seeing here is analysis, which has been presented in one of the forums of the clinicians, where they have shown that the ctDNA levels declined greater than 90% within 2 weeks of the treatment. So although very short-lived, but has great significance in terms of saying whether the treatment is really working without doing any imaging, without doing anything else, but taking out blood and counting or analyzing ctDNA, counting CTCs or analyzing ctDNA. Not only that, they have gone ahead and they have been able to detect some fusion events and in many genes. And that's a good story to tell, because we always thought about it's too little a DNA, how are we going to ever achieve what we wanted? The sensitivity of the entire experimentation has changed drastically because of how the digital droplet PCR works or beaming works, or there are multiple methods actually to just use one single cell and get the job done. So you could analyze every cell. You can talk about heterogeneity right away. Consider that one patient showed all these fusions, and you already know it is not really a one cell fusion event, it might be multiple. It can so happen that the same cell might have it, but the chances are really, really low. This is to just show you that somatic mutations that we have found in ctDNA versus what we have got it from primary tumor, from the biopsies, is pretty similar, not exactly the same, but you could use blood to actually work with breast, cervical, colorectal, or melanoma. So much of effect in terms of even in lung, for that matter, I see it pretty okay to find out the mutation prevalence. So you know that we could substitute the blood DNA for tumor biopsy wherever tumor biopsy is not possible. So these are some of the things pretty much known and way ahead in the phases to bring it to the clinic. Something more that we are learning is about the tumor-educated platelets and exosomes. And tumor-educated platelets, I'll just show you quickly one slide on that, where you see that you're looking at the mRNA profile. What platelets do is sequester mRNA, miRNA, DNA, and all of it. So if we isolate platelets and study platelets from the tumor individuals, they are very, very different than those from the normal. And what you're seeing is from a bone marrow to the blood. And if you look at the pattern there, you should be able to say normal versus tumor, it's just the reverse. And that's such a signature mRNA repertoire. So not only at the DNA level you are able to see it, you are also seeing at the transcript level what are the changes. and miRNA as a biomarker can be easily utilized to diagnose and identify tumor types and study mutations. Exosomes are on the pretty similar line, actively released vesicles which carry DNA, RNA, protein, and these have been used for quite some time, but they are becoming important for studying all the related RNA and DNA, whether it is long non-coding RNA, miRNA, and slowly we will understand the utility of all of these in cancer diagnosis. What you are seeing is one example of the tumor educated platelets, and you see mRNA which are captured, and platelet enriched plasma is taken, cell-free RNA is extracted, and you can do a PCR for PDL1, CK19, whatever you want, EGFR. You know you will see it at the level of mRNA, not at the level of DNA, but also at the level of RNA, the changes that are associated with the treatment. This is a quick comparison of analysis of CTCs, cfDNAs, and exosomes. And the analysis here, pretty simple. If mutations, the answer is yes, all can detect it. Epigenetic modifications, the answer is yes, all can detect it. RNA transcription profile, cfDNA will not give you. Phenotypic studies of the cells, cfDNA and exosomes do not tell that, whereas the cells, CTCs will do it. Inflammatory response is only by exosomes. Analysis of RNA as well as DNA protein can be done from CTCs and exosomes, but not from cfDNA. So there is some differences between this, where CTCs would be also required, cfDNA and exosomes. We can figure out which one to use where and which ones will make its way through the clinic. One of the most important part, and that's why I highlighted, is can we utilize biobank samples? And the answer is you can for the cfDNA and exosomes. You cannot use it for CTCs. So to wind up what I said till now, liquid biopsy has helped and will be helping, hopefully, in every clinic by a rapid assessment of biomarkers in cancer patients for whom the solid biopsies are impossible due to restricted or extremely risky access possibilities. So it is not to replace biopsies, but to really help those where biopsies are not possible. And that's where we have to begin, because we are not there yet to say everywhere we'll be able to use it. After you have diagnosed it and you want to monitor it, it can be used for a follow-up and treatment efficiency testing. Of course, it also helps to find out if a person would develop resistance to therapy. Thank you all for your patience. If you have any questions, please let me know.
The participants can raise their hand if they have any questions. Ma'am, just one question. Where are the facilities available for all these molecular genetics testing in Bangalore, ma'am? Liquid biopsy and other ancillary tests?
I seriously have no answer to this question. I don't know where in Bangalore it is available or who is doing CTCs at Bangalore. But, you know, it is limited to sort of more of a research in India than its clinical utility. I just showed you examples from UK and US, where they have at least collaborated with all these companies making or designing all these methods or technologies to help with diagnosis. So in India, it is not yet there, I guess. I do not know if anybody is using it. It's more at the research level where we are collaborating with doctors to do initial studies. So if we can set it up, it might just work out.
Thank you, ma'am. Thank you for your valuable path-breaking talk on liquid biopsy in cancer diagnosis, making cancer diagnosis less invasive and introducing us to various new methods and techniques of liquid biopsy. Thank you, ma'am.
Thank you all. You have any questions?
No, ma'am. There are no
All
questions.
right. All right. I'll stop sharing.
No. Yes. The final session is on the clinical application of molecular pathology by Dr. Manjunath GN, Assistant Professor of Radiation Oncology, SDMC Kolar. I request Dr. Hemlata A. and Blood Bank Officer, Department of Pathology, to introduce the speaker.
Good afternoon, everyone. It is my privilege to introduce the next speaker, Dr. Manjunath GN. He is Assistant Professor from Department of Radiation Oncology, Sri Devaraj Medical College. He is undergraduate from our own institute, that is Sri Devaraj Medical College. He did his MDRT from MS Ramaya Medical College, Bangalore, and HB N1 Fellowship from Tata Memorial Hospital, Mumbai. His areas of interest are head and neck cancer, re-irradiation, brachytherapy, SRS, and SBRT. He has got a travel fellowship for paper presentation in ArioCon 2011. So he has various publications, the important ones being in cervical cancer patients and in head and neck cancer patients. He also has experience in treating patients using LINAC models, telecobalt machines, brachytherapy. His chemotherapy practice includes using various single agent and combination regimens for various solid malignancies. Over to you, Dr. Manjunath.
Good afternoon, everybody. I'm Dr. Manjunath from Department of Radiation Oncology. I'll be talking about the clinical applications of molecular pathology. Molecular pathology, in essence, is same as the classical pathology, but it differs in terms of the way it approaches the specimen. In morphological pathology or the classical pathology, we look at the structure of the cells, the protein content, how well it stains. Whereas in molecular pathology, we look at the proteins expressed, the genetic mutations that are present inside the specimen from the malignancies or the body fluids. So this information is very important because cancer is a molecular, is a genomic disease. It's a problem with the genomic. So in cancer, finding these proteins and genetic mutations is of utmost importance. The advantage being we can diagnose quicker. We can decide on the we can make a conclusion about the prognosis of the disease, and we can guide treatment. So this discipline of molecular pathology is an emerging discipline within pathology, and it draws its knowledge base from multiple other disciplines such as clinical pathology, genomics, proteomics, and biochemistry. Regarding cancer, it has as I said, it has a genomic pathology. Basically, the genes in a cell have a balance, and this balance can get disturbed because of mutations, and all the physical manifestations of a tumor and its symptoms are because of these mutation. This leads to excessive and uncontrolled, uncoordinated division, which we call as cancer. So we say, when we see a patient, this is an ulcerative growth, this is the problem, this is the cancer. Yes, this is a problem, but this is not the problem that we are dealing with. Some say, okay, this is the problem, this is how the problem appears, but even this is not the real problem. The real problem looks like this: a minor chemical change in a biological molecule. So this minor chemical change in a biological molecule is called as a mutation. That is the real problem in cancer. So we will come to this again and again during the presentation. This concept of cancer being a problem with the genome or the genetic material is not new. This was proposed almost 100 years ago by Dr. Theodore Boveri. He was a zoologist. He conducted experiments on fruit fly, and he proposed his theory, systematic somatic mutation theory of cancer, in 1914. According to him, the cancer happens because of chromosomal changes. This proposal, though, was not initially supported, but it was ultimately proven right 50 years later, when Philadelphia chromosome, the BCR-ABL fusion gene, was found. So coming to the clinical applications of molecular pathology, many of the molecular pathology techniques have found application in cancer treatment, and they are responsible for some of the most successful cancer treatments. They have contributed significantly, and they have reduced mortality and morbidity in cancer patients. Let's see a few examples. The earliest breakthrough in molecular pathology leading to a major clinical achievement was in terms with ERPR receptor testing. ERPR test is an immunohistochemistry test, and through this we can find whether the ERPR is overexpressed or not, or amplified or not. The hormone therapy in CA breast is not a new concept. It has been there from a long time, whereas it was not very popular because in an unselected population, response to hormone therapy is as low as 25%. Only around 1 in 4 patients respond to hormone therapy if we give it to an unselected population. But when testing for ERPR was introduced, we could find and select patients who are more likely to respond to hormone therapy. That means only ERPR positive patients, when they are given hormone therapy, the response rates increase by 56%. So compared to 25%, that's almost a increase of 31% increase in response to treatment. So this made a hormone therapy come back and become one of the more mainstream treatments in CA breast patients. Let us see the relationship between estrogen receptor and progesterone receptor a little more in detail. If a person is ERPR positive, both positive, then the rate of response is likely to be around 78%, very high. In patients who are ER positive and PR negative, the response rates to hormone therapy is around 34. When both are negative, it's only 10%. And if it is ER negative and PR positive, the response rates are likely to be around 45%. So this tells us that by doing ERPR test, we can select the right group of patients for the right treatment, and right treatment for the right group of patients. So by giving hormone therapy to ERPR positive patients, we are making sure that they get benefit of hormone therapy, and by not giving hormone therapy to ERPR negative patients, we make sure that they get other treatments and hence get benefit of the right treatment for them. So here the molecular pathology techniques are helping us select the right treatment for the right patient. So good treatment decision can be taken with the help of these techniques. Again, this graph shows that ERPR positive patients do well. So this line is way higher and separated from the other two. So ERPR positive, both positive patients have a better disease-free survival, whereas ER positive, PR negative patients have slightly lesser, and both negative patients do bad. So it not just it helps us to decide on prognosis also. It helps us to prognosticate the disease and convey it to the patient. So ERPR testing is helping us make better treatment decision and decide on prognosis of the patients. The next breakthrough came in the form of being a form of the ability to identify HER2/neu receptor amplification. HER2/neu is a membrane tyrosine kinase receptor encoded by ERBB2 gene located on chromosome 17. HER2/neu is overexpressed in 15 to 30% of breast cancer patients, and HER2 overexpression is associated with aggressive tumors. These tumors spread very quickly, metastasize quickly, and they recur faster, and they grow quickly. So these tumors are more aggressive tumors. Hence, they always carried historically poor prognosis. How does HER2/neu do this? HER2/neu, mutations in this ERBB2 gene leads to overexpression of HER2/neu genes, HER2/neu receptors on the surface, and these HER2/neu receptors have a tendency of forming dimers. Once the dimer formation takes place, there will be autophosphorylation and leading to formation of tyrosine residues. These tyrosine residues initiate signal transduction pathways such as PI3K, MAPK, mTOR, and PKC. So once all these signal transduction pathways are made to get activated, they will lead the cell into progression and proliferation. So this is what is making these HER2 positive tumors more aggressive. And HER2/neu also blocks apoptotic signals to make the cells survive longer and proliferate more virulently. So by blocking HER2 receptor signal transduction, we can achieve reduction in the rate of cell division and make the tumor less aggressive. So, but detecting HER2/neu amplification is the key, because HER2/neu is present only in around 15 to 30% of patients. For these treatments to succeed, we should select the treatment population who are going to benefit from these treatments. So the techniques used for this is IHC and FISH techniques. So this, I guess, everybody can recognize the immunohistochemistry for HER2/neu, and if the test score is 3+, that means the HER2/neu is positive, and the patient can benefit from anti-HER2/neu treatment. If it is 0 or 1+, then it is negative, and there's no benefit of giving anti-HER2/neu treatment. Whereas if it is equivocal, if it is 2+, then that sample must be subjected for FISH test, because this is considered as a weak positive, equivocal or weak positive. But if the FISH test comes positive, then that patient will benefit from anti-HER2 treatment, and if it is negative, then there's no use of giving anti-HER2 treatment to such patients. Looking at the anti-HER2 therapy treatment options, the first one to be introduced was trastuzumab. Trastuzumab is a monoclonal antibody. It is recommended as an adjuvant therapy for all non-metastatic CA breast patients who show amplification of HER2/neu. That is, if HER2/neu positive, all patients non-metastatic should get at least 1 year of Herceptin or trastuzumab. It's given every 3 weekly. Use of trastuzumab reduced the recurrence by around 50% and mortality by around 33%. The graph shows the two curves, getting separated over a period of time. So patients who are getting Herceptin are doing much better than patients who got only chemotherapy. and it reduces mortality by around 33%. And we have to remember this is happening in a group of patients who are HER2 positive, who always have a poor prognosis. This poor prognosis group is now doing better. We are giving drug, and their recurrence rates and mortality rates have become better. And it can also be used in metastatic patients, and it improves survival in these patients as well. The next drug to be introduced was pertuzumab. So it's again an anti-HER2 monoclonal antibody. It is recommended as a neoadjuvant and adjuvant therapy for non-metastatic CA breast patients who are HER2 positive. But in combination with trastuzumab, it is never given alone, but it's always used along with trastuzumab. This has again showed a significant benefit in improvement in survival. If we see the curve, the blue curve, which is combination curve, combination arm of pertuzumab with trastuzumab and docetaxel, has shown it stays up all the time, and it shows better survival compared to the trastuzumab plus docetaxel only arm. So the recurrent disease-free survival, overall survival, everything is much better. So trastuzumab, pertuzumab and trastuzumab is given as a combination for over a year, and it has also been tried in metastatic CA breast, leading to improvement in survival. So next group of drugs are very innovative ones. These are called as antibody chemotherapy drug combination. So here the monoclonal antibody trastuzumab is linked with a chemotherapy drug. In this first example, trastuzumab emtansine. Here the trastuzumab is the monoclonal antibody and chemotherapy drug is the emtansine. So this combination is a very innovative one. Here, when this combination enters into the body, it goes to a place where HER2 overexpression is there, that is on the tumor cell, and binds it. And once it is bound to the HER2 receptor, signal transduction will get blocked. That will anyway happen. But after some time, this receptor, along with the monoclonal antibody and the chemo drug conjugated to it, is internalized, and the chemo drug is released because of the breakage of the cleavage of the bond between these two. The chemo drug is released. Emtansine is a it's a tubulin. It binds to tubulin and it inhibits its proliferation. Leading to mitotic arrest. It's very similar to the paclitaxel or docetaxel drug that we use in clinical practice. So it blocks the tubulin formation and leads to mitotic arrest of the cell, and the cell undergoes apoptosis. Here, HER2 is overexpressed only in tumor cells. The chemo drug is delivered selectively to the tumor cells. So if we think of targeted therapy, this looks like a double targeted therapy, because trastuzumab is also targeting the cell, and it also takes along with it a chemotherapy drug, which is also delivered into the cell, leads to cell death, so cancer cell death. So this treatment has already been proven to be useful in clinical trials. It was used for patients who have exhausted all other treatment options. CA breast patients, metastatic. After all the treatment options have been exhausted, it was compared with lapatinib with capecitabine, and it improves survival by 5 months compared to the standard treatment or standard last line of treatment. Let us see how it works. So this is the antibody drug combination or the conjugate, and it binds with the HER2 receptor and it gets internalized, where it is broken down and the chemo drug is released, and chemo drug acts on the cell and kills it, and sometimes chemo drug comes out and also acts on the surrounding cells, whereas the normal cells which are not overexpressing the HER2 will not get affected because of this thing. So this is a true targeted therapy. But the target has to be known. So that is what molecular pathology allows us to do. It allows us to meet our target, the true target, which is the biochemical. It's a minor chemical change in a biological molecule. So it helps us, understand the tumor better, and after that find the targets and attack these targets using these innovative molecules. So the next one is again an antibody chemo combination, which is trastuzumab deruxtecan. So here the mechanism of action is very similar. It is a it's a conjugate, and deruxtecan is a topoisomerase enzyme inhibitor. So topoisomerase enzyme is required for unwinding of the DNA at the time of cell division. If this enzyme is blocked, unwinding of the DNA doesn't take place, leading to formation of multiple DNA breakages and ultimately cell death. So it's approved for use in metastatic HER2 positive CA breast, and median duration of response is around 14.5 months and a response rate of around 60%. So I mean, this duration of response is 14.5 months, which is a very long period and very good for a patient who has exhausted all other treatment option. This last treatment option gives a very good survival of around 1 to 2 years, and that response can be expected in up to 60% of patients. It should be called as a very big breakthrough in treatment, and this drug has been approved by FDA and European Union in January 2021. That means very latest drug, showing very good result, very promising drug, not just in CA breast, but it has also been tried in CA stomach. CA stomach patients do express HER2/neu, and in these patients it has showed response in around 40% of patients and progression-free survival of around 5.6 months. So newer drugs, targeted therapies showing very good response, and the targets identified and targeted because of molecular pathology. And the next drug is trastuzumab deocarmazine. Again, it's a antibody chemo combination, and the mechanism of action is very similar. Here, deocarmazine is a alkylating agent. It causes direct DNA damage, and this drug is in phase 3 clinical trials, but it is showing promising result. Here is a picture. This is the monoclonal antibody, and this is a linker molecule, and this is the chemo drug attached to it. So once the whole complex get internalized, the linker molecule is broken down and the chemo drug is released into the cell. So there are other molecules which can target HER2. They are lapatinib, tucatinib, and neratinib. They're all approved for metastatic HER2 positive CA breast in combination with chemotherapy. Whereas neratinib is also approved for adjuvant treatment. Basically, it's extended adjuvant therapy after 1 year of trastuzumab. So a non-metastatic HER2 positive CA breast patient can get trastuzumab for 1 year and then 1 year of neratinib. So this has shown to improve survival, long duration treatment. However, it provides very important survival advantage and reduction in recurrences. The next success for molecular pathology in oncology came in the form of chronic myelocytic leukemia, where the Philadelphia chromosome was found, and its basis and its molecular basis, which is the BCR-ABL fusion gene, was found. It was found that this BCR-ABL fusion gene is a single specific genetic abnormality in CML. So all CML patients had this abnormal gene or a fusion gene, and it could be detected using PCR-based genetic molecular testing, which is commonly used. There are two types of tests, qualitative and quantitative. Qualitative test is the presence or absence of BCR-ABL fusion gene and the type of rearrangement, whether it's a minor rearrangement, major rearrangement, what type of rearrangement can be found using this test. And quantitative test is to measure the number of copies, how many copies of this BCR-ABL is still in circulation, and it's useful for monitoring response to treatment, whereas qualitative test is useful for diagnosis. So qualitative for diagnosis and quantitative for monitoring response to treatment. Imatinib is a small molecule tyrosine kinase inhibitor, and it counteracts the tyrosine kinase activity of the BCR-ABL gene product, or the protein produced because of BCR-ABL. So BCR-ABL gene product is a it causes tyrosine. It has tyrosine kinase activity, activates all the intracellular signal transduction pathways. This imatinib blocks this effect, and it was approved in 2002. Daily dose of around 400 mg, single tablet every day, And in case of more aggressive disease, it can be given at a doses of around 600 to 800 milligram. IRIS trial showed that 85% of overall survival could be attained at 8 years. That's a phenomenal, survival, around 85% at 8 years. For CML, initially it had a median survival of around 6 months to 1 year if the patient did not undergo bone marrow transplantation. So from there to 85% survival at 8 years was a phenomenal increase, major achievement. So the target was, the target was found because of molecular studies. Many patients who responded to imatinib continued the treatment for up to 15 years, and their response to treatment was sustained for that long period. Today, life expectancy of a CML patient is nearly same as that of general population. So if we have a 50-year-old CML patient on imatinib, he can be expected to live the same duration of life as that of a normal person without malignancy. So imatinib has done wonders in CML. And moreover, imatinib is very well tolerated, excellent quality of life can be achieved. But stopping imatinib usually leads to molecular relapse within 6 months. So the advice is to continue imatinib for as long as possible. And there are second line drugs. If the patient files on imatinib, dasatinib, nilotinib, and bosutinib can also be used. They also are equally good, and some of them are much better than imatinib. So if we know the target in the tumor, so attacking it or contracting it with a proper molecule becomes a lot easier. So that's what has been done in ERPR positive breast cancer, HER2 positive breast cancer, and CML that we have still till now seen. The kind of the control that was achieved in CML patients has not been replicated in any other malignancy except gastrointestinal stromal tumors. Here, gastrointestinal stromal tumor was thought to be very aggressive tumor, and prognosis was very poor even after complete surgical excision. And it did not respond to radiation or chemotherapy. So none of these work. Wherein these patients, the breakthrough came in the form of KIT proto-oncogene mutation. So they found out that KIT proto-oncogene mutation is present in around 80% of all GIST specimens. And at the same time, we got imatinib. Imatinib was invented at the same period of time. And when they found out that KIT kinase, that is the gene product of KIT proto-oncogene that drives the cell proliferation in these tumors, it was very similar to the BCR-ABL kinase that we found in CML. So the KIT kinase and BCR-ABL kinase very similar. So they thought, okay, if imatinib can work there, why can't we use it here? One patient was treated, and that patient improved significantly. He showed very good quality of life and survival. So then trial was conducted, and trials showed very good results, and imatinib became a standard of care for treatment of gastrointestinal stromal tumor. Today, imatinib is used in neoadjuvant setting, adjuvant, and palliative setting. All any situation in gastrointestinal tumor, imatinib has shown benefit there. So this patient, some of them had PDGFR mutations in around 10% of patients. So remaining 15% with no type of mutation, no mutations, are all termed as wild type mutations. So mutational testing for KIT proto-oncogene and PDGFR is helpful in predicting the usefulness and response to imatinib and deciding its dose as well. So now here comes the role of the molecular pathology. The molecular pathology will tell us what are the mutations present in a particular specimen of GIST, and we know what to do, how to treat each particular mutation. If the patient has this specimen has KIT mutation and exon 9, those patients should be better treated with 800 mg instead of 400 mg. The 400 mg is the standard dose, but we should consider giving 800 mg for these patients, because these patients do well with higher doses of imatinib. Whereas if a patient has exon 18 mutation in PDGFR gene, then this patient is not going to benefit from imatinib. and in wild type, imatinib might not work. So the molecular testing of GIST will give us information about whether imatinib will work or not, what dose is better, and when to select other treatments instead of imatinib. So looking at the clinical benefit of imatinib in GIST, in case of metastatic GIST patients who respond to imatinib, who are being treated with imatinib, median survival is around 57 months. Compared to those patients who are not treated with imatinib, the median survival is only 9 months. So 9 months to 57 months. So the treatment is making such a huge difference in outlook for these patients. Even in patients who are operated, tumor fully resected, if they're high risk, no imatinib, 3-year recurrence-free survival is only 49%, whereas treatment with 3 years of imatinib in these patients will increase the recurrence-free survival to 83%. So patients who are taking imatinib are 50% less likely to recur compared to those who are not taking imatinib, if they are high risk, just even if they have got operated. So imatinib doing a very good job. But again here, the point is now we know the target. Without knowing the target, we couldn't have achieved this. So the target is being made known, and once the target is known, it is easy to hit it or make it go silent and make the tumor bring the tumor under control. So next one I'll be discussing about is the new group of drugs or new type of treatment altogether called as immunotherapy or immune checkpoint inhibitors. The immune T cells are capable of recognizing and destroying cancer cells. It was known from a long time, but most of the cancer patients, the immunity doesn't attack the cancer cells. So this was a mystery, but research revealed that cancer cells express certain negative regulators of T cells, such as CTLA4 and PD-L1, which negatively influence the T cell mediated immune response. So when T cells approach these cancer cells, since these cancer cells are expressing CTLA4 and PD-L1 in large quantities, the T cell becomes mute. It doesn't do its work. It doesn't attack the cancer cell. That is how the cancer tumors have been escaping from immune system. So this was found in around 1990 and 2000, and drugs were developed to counteract this. So again, just to reiterate the same thing. So the tumor is producing PD-L1, which is a ligand for PD-1 receptor present on the T cell. When they bind, the T cell becomes dormant. It doesn't attack the cancer cell. So this kind of thing has been going on. That is how the cancer cell was escaping from immunity. But now we produce monoclonal antibodies against PD-L1. So this monoclonal antibody binds with PD-L1, neutralizes it, and the tumor will not be able to pacify the T cell. The T cell becomes, when it comes near the tumor cell, it will recognize the tumor cell for what it is and will attack it. Another way of achieving the same thing is making antibodies against PD-1 receptor on the T cell. Once the PD-1 is blocked because of these monoclonal antibodies, the interaction between PD-1 and PD-L1 cannot take place. Once this interaction is blocked, the T cell doesn't become dormant. It gets activated once it approaches a cancer T cell. It activates the antigen presenting cell, and the immunity will attack the cancer cell. So this is basically the cancer cell was getting away, or say it was getting away from immune system. It was basically hiding from the immune system, and this mechanism is now being blocked because of the monoclonal antibodies that we are giving. And since the cancer cell cannot hide from the immune system anymore, it will be attacked by T cells, and the immune system will start killing the tumor cell. Again, another picture here, a monoclonal antibody against the CTLA4 protein expressed on the T cell. and this protein blocks the CTLA4, and thereby ability of the T cell, ability of the tumor cell to pacify the T cell is lost. So T cell will act against the tumor cells. But then how do we find the tumors which are overexpressing these molecules, PDL1 and CTLA4? Is the tumor overexpressing these molecules or not? If we, the treatment will work only for those tumors wherein PDL1 is overexpressing. So for this, immunohistochemistry technique is available. This is an example. This is a picture of IHC for PDL1 overexpression. And regarding CTLA4, mutation analysis is done or blockade bioassay is available. So these tests are done for detection of CTLA4 overexpression, and in patients who are overexpressing PDL1 and CTLA4, drugs are available, immunotherapies are available, but these tests must be performed to identify the overexpression or amplification of these markers to confirm that the immunotherapies will be able to work against this particular tumor. So immunotherapy drugs that are available right now are the anti-CTLA4 antibodies, namely ipilimumab and tremelimumab. I know they are very difficult to pronounce, but they are equally difficult to procure also. They are extremely expensive drugs. Some of them have been launched very recently, so they are extremely expensive, but nonetheless, they are very good and provide survival advantage to a lot of metastatic patients. Regarding PDL1 monoclonal antibodies, avelumumab, durvalumab, and atezolizumab. So these three molecules act against PDL1 protein expressed by the tumors, and anti-PD1 monoclonal antibodies are pembrolizumab and nivolumab. So these all molecules have completed their clinical trials, and many more are undergoing clinical trials. So clinical use of immunotherapy drugs, a very big list of tumors wherein each of these drugs are active have been found. Multiple trials are still ongoing to find tumors in which these agents can be beneficial. I'll just I'll just tell one example. Ipilimumab can be used in metastatic melanoma. Again, melanoma is one tumor where radiation is usually not so useful. Chemotherapy is not so good. Renal cell carcinoma, again, the similar picture. No radiation, no chemotherapy. Only surgery, the treatment option. Hepatocellular carcinoma, again, chemotherapy, radiation is not very useful. Malignant pleural mesothelioma, NSCLC. NSCLC, a lot of chemotherapy is there, but still nothing is sufficient. So even in those tumors where chemotherapy, radiation doesn't contribute much, immunotherapy is showing very good survival for these, providing very good survival for these patients. For example, platinum-resistant head and neck cancer is one of the indications for pembrolizumab. In these tumors, platinum and taxanes are the most important group of drugs. But once they are not useful, once the tumor becomes resistant to these two drugs, no good option is available. But pembrolizumab has come in there, and it provides around 9 months of survival, which is very good. Clinical use of immunotherapy agents. Initially, single drugs were tried, but then they've ultimately found that combination of drugs is much better. Ipilimumab and nivolumab have found to be very effective, and many indications now say a combination of these two drugs is the one which should be given for a particular malignancy. So the combination is a very successful one, and it is being used in many tumors. In 2017, pembrolizumab was approved for use in any solid tumor with mismatch repair deficiency. So this was kind of a breakthrough, because if you see here, so all these drugs are actually approved for treatment of a particular type of tumor. The tumor basically represents anatomical site and a histology. For example, small cells see a lung. So small cell is the histology, lung is the anatomical site. So histology and an anatomical site. These are the two things that were taken into consideration when approval was being given. But if you see this, approval, pembrolizumab can be used in any solid tumor if it is having mismatch repair deficiency. So this was the first time a drug is approved on the basis of tumor genomics rather than morphology. Here now, we are not worried about the anatomy or the morphology of the tumor. We are only bothered about what are the genetic or the genomic characteristic of the tumor. If there is mismatch repair or microsatellite instability, pembrolizumab can be given. So the molecular pathology techniques are now directly guiding the treatment. It is not indirectly through the anatomy or morphological characteristic of the tumor. The molecular pathological techniques can now directly become indications for treatment, as has happened in pembrolizumab. And I hope this is a very good trend. And if we can test the tumor, find the genetic or the genomic problems or the genomic deficiencies in this specimen, we can we can appropriately treat it. Molecular pathology has an important role to play when it's about diagnosis. So molecular diagnosis of cancer has always been morphological. We were always taught, and we always teach that pathology, biopsy and FNAC are compulsory for diagnosis of any cancer. Biopsy is the gold standard, but now the scenario is changing slowly with introduction of molecular techniques. In some tumors, even if there is no morphological diagnosis, if we can demonstrate the mutation characteristic of that particular tumor, then the diagnosis can be considered to be confirmed. For example, if we find IDH1 and IDH2 mutations in a brain tumor, it is glioma. It cannot be anything else. So finding a mutation and linking it with a diagnosis is a revolutionary thing, and it has already been proven. IDH1 and IDH2 mutations in gliomas are diagnostic of gliomas. BRAF mutation in thyroid FNAC. So FNAC specimen not very conclusive, but if we do mutation analysis and we find BRAF mutation, it becomes a diagnostic for it is a diagnosis of papillary carcinoma of thyroid. ALK arrangement, if it is present, the specimen belongs to anaplastic large cell lymphoma. KRAS codons 12, 13, and 61 mutations in bile duct brushing, it is diagnosis of cholangiocarcinoma and pancreatic CA. So molecular diagnosis is very much here, and it's already helping. If molecular diagnosis is achieved, then morphological diagnosis might not be required. Guiding treatment is one of the major things in molecular pathology. In lung adenocarcinoma, I have listed a few mutations. For example, EGFR exon mutations, 18 to 21. If they are found, then it means that the patient will respond to EGFR inhibitors. The EGFR inhibitors being geftinib, erlotinib, afatinib. So these drugs have actually revolutionized treatment of adenocarcinoma in patients who have got EGFR expression. So these are again tyrosine kinase inhibitors, small molecule tyrosine kinase inhibitors, which are less toxic, easily tolerable, and very good at controlling lung adenocarcinoma. Survival has improved by a year or two after these treatments have been introduced. But if this EGFR has T790M mutation, then there is resistance to EGFR mutation inhibitors. We cannot treat these patients with erlotinib, geftinib, or afatinib, whereas we will have to give the patient third generation EGFR inhibitors, namely osimertinib. So if we find exon 18 to 21 mutation, we can give the first and second generation ones, and if there is T70M mutation, we will have to give only third generation EGFR inhibitors. If the specimen also has KRAS codon mutations, then EGFR treatment will not work. If the patient has MET amplification, then anti-EGFR treatment will not work. So now there are at least four genes and multiple mutations that we just discussed. How to decide on treatment? So the treatment is decided based on so many factors, so many genes and mutations. So knowing about all these things helps us make right decisions for the patient. So empirical treatment is not advisable. Testing for all these mutations, and after all the information is found, if we can make the final decision, it is always better. ALK rearrangement, if it is found in a lung adenocarcinoma, it means the patient will respond to tyrosine kinase inhibitor, a different one, namely crizotinib. And this treatment also gives very good survival advantage in a metastatic lung adenocarcinoma patient. So ALK rearrangement is another important genetic target, the mutational target that we always look for. So guiding treatment in colorectal adenocarcinoma. In these patients, EGFR monoclonal antibodies are very important and very good one. I mean, they give good benefit for the patient. KRAS codons 12, 13, and 61 mutation, if they are present, if they're mutated, then cetuximab, which is the EGFR monoclonal antibody, will not work. Again, the same for NRAS codon mutations and BRAF mutations. So if these mutations are found when we are analyzing the specimen, then it means that anti-EGFR monoclonal antibody, namely cetuximab, will not work in these patients. So the treatment is guided by the mutation profile in the tumor. Again, in glioma, a very common example, MGMT promoter methylation, if it is present, then favorable response to alkylating agents such as temozolomide. Temozolomide is an alkylating agent. It's available in oral preparation. Has actually given significant benefit to glioma patients. It has almost doubled the survival in these patients, but it will not work for everybody. Only those patients who have MGMT promoter methylation will benefit from temozolomide. So we can avoid this treatment, which is also having significant toxicity in patients who do not have MGMT promoter methylation. So finding this MGMT promoter methylation is very vital, and molecular pathology helps in that way. Cutaneous and mucosal melanoma, BRAF codon mutation, V600 mutation, then we can treat these patients with BRAF inhibitors. And we can expect prognostic information also from molecular pathology. BRAF mutations in colorectal carcinoma, it's a bad prognostic factor, and the IDH1 and IDH2 mutations they have got. It means if these mutations are present, it means that these patients have got good prognosis. Next, coming to the elephant in the room, the next generation sequencing. So next generation sequencing is not a futuristic technology. It's already here. We are already using it, and it's also commercially being advertised and available for patients. In this test, a large number of genes can be investigated with just a single test. So a single test can give information about large number of genes and large number of mutations in these genes. Enormous amount of information is generated. Vast number of genetic alterations are detected. An example that is already commercially available, cancer mutation profile test. It looks for 1,850 mutations in around 50 important genes. I mean, that's a lot of information. And what do we do this with information? So this data is too big for analysis and very difficult to create algorithms for 1,850 mutations. So this is where, I mean, how to analyze, this data? It's a question that's troubling everybody. But artificial intelligence comes here. It comes in, and this data, large amount of data, can be analyzed by artificial intelligence, and in future this has the potential of becoming the standard of care. So when we take a biopsy, we send for histopathology, and it looks as though in future we will be taking a biopsy and sending it for next generation sequencing, do a mutation profiling of these cancer cells, and find out a good amount of information about what these what mutations are present in each of these individual important genes, and how this tumor is going to respond. Is it going to be dormant, or is it going to be very aggressive? So, and what treatments are going to benefit it? All these questions, I guess, artificial intelligence will help in analyzing all this data and answering all these questions. Next thing is the liquid biopsy. Liquid biopsy is a simple blood test. The blood is drawn from a cancer patient, and it is subjected to analysis, wherein we find the circulating tumor DNA. When a tumor cell dies, its DNA is released into the blood, and we try to find this circulating tumor DNA, and this is purified, and and it is analyzed. This circulating tumor DNA, it can be subjected to next generation sequencing that we just that discussed. Next generation sequencing can provide comprehensive view of this cancer cells genetic makeup, what mutations are present in each of these genes. The whole information can be got without even touching the tumor. The tumor has shed the DNA into the blood. We take the blood sample and extract the tumor's DNA, and DNA is analyzed, and all the mutations present in this tumor can be found out. Or alternatively, we can do PCR, and this offers more targeted approach, especially which is suited for detecting minimal residual disease and for monitoring treatment response and disease progression. So when we already know what tumor the patient has, we can do PCR, a more focused approach for monitoring of treatment and for identifying the disease progression. Advantages of liquid biopsies: the major advantage being it's so less invasive. Taking a blood sample is a lot easier than taking a biopsy sample from the middle of lung. So it's less invasive, more easier, less risky. It can be used for diagnosis of cancer. We can take the sample, and this circulated tumor DNA, when subjected to next generation sequencing, we can identify where this tumor started from, whether it's from lung or whether it's a sarcoma. This kind of information can be derived, and we can diagnose the cancer. It may also be used to help plan treatment. So we have already seen a lot of genetic information is useful in deciding which treatment is beneficial for the patient. So we can use the same. Same applies here. We take the circulating tumor DNA, and then we get the information and plan the treatment. It also helps to monitor response to treatment. If the patient is responding to treatment, the circulating tumor DNA copies will come down over time. It also helps to detect recurrences, and the circulating tumor DNA which has come down, if the patient recurrence because will again increase. So more number of copies will be found, or the copies with a particular specific mutation will start reappearing in the blood. That will help us think of a recurrence and try to find the recurrence. And being able to take multiple samples of blood over time will help us understand what kind of molecular changes are taking place inside the tumor. So when the tumor is 2 centimeter, what are the mutations present in it? When it grows to slightly bigger in size, what mutations has it acquired over a period of time? As the time passes, tumors acquire more and more and more mutations, and we can follow up these tumors over a period of time, see what kind of mutations are present in these samples and what kind of mutations happening over a period of time. So this kind of studies can be done if liquid biopsy is available to us. So other applications, genetic screening for cancer predisposition, which is a huge topic in itself, so I'll not be discussing about that today. So we come to the end of my presentation, and I thank you all for a very patient listening. Thank you.
If there are any questions, you can raise your hand.
Thank you, sir, for your inspiring, interesting, informative talk on clinical application of molecular pathology. I personally was inspired that how chemotherapy is benefiting and doing wonders in CML and GIST patients and immunotherapy in solid tumors. So I thank once again. Now I request Dr. Swarup Raj, sir, Associate Professor, Department of Pathology, to propose the vote of thanks for today's session.
Good evening, everybody. This brings us to the end of today's session. So this was an academic feast on the topic molecular pathology, where they have covered everything, including the methods, the application, and the clinical application of molecular genetics. So it's my pleasure to propose the vote of thanks on today's occasion. Firstly, I would like to thank our administrative team at Sri Devaraj Academy of Higher Education and Research, which is led by our founder chairman, Sri R.L. Jalapaji, Secretary, Sri G.H. Nagaraja sir, Administrative and Finance Director, Sri Rajendra J., Honorable Chancellor, Sri Rajesh N. Jagadale, Honorable Vice Chancellor, Dr. Pradeep V. Kumar, Registrar, Dr. K.N.V. Prasad sir, Principal and Dean, Dr. Sriram Lusa, and Medical Superintendent, Dr. S.M. Azim Mohyuddin. I would like to thank the speakers of today's CME, without whom this wouldn't have been possible. So I thank our speakers, Dr. S. Rajendran sir, Professor of Pathology, Sri Devaraj, Sri Ramchandra Institute of Higher Education and Research, Dr. Vani Santosh, Professor, Department of Neuropathology in IMHANS, Dr. Swarna Shivakumar, Senior Consultant, Histopathology and Cytology, Apollo Hospital, Dr. Bibha Chaudhary, Faculty Scientist at Institute of Bioinformatics and Applied Biotechnology, Bangalore, and Dr. Manjunath GN, Assistant Professor, Department of Radiation Oncology at our institute. I'd like to thank the organizing team led by our HOD, Dr. Kalyani R, and all my fellow colleagues and postgraduates. A special mention to Dr. T.N. Suresh, Professor of Pathology, who helped coordinate the entire event. I thank all the participants who have made today a great success. I'd like to thank everyone who was a part of today's function, directly or indirectly, including the librarian, IT team, etc.